Thanks. Beautiful. All right, and then Daphne, if you want to go ahead with roll call.
Thank you so much. Antoinette Awachi. I know she's here on the phone. Brian Judy.
Present.
Mary Beth Ongrave.
Present.
We know Holly Joe is conducting the meeting. Max Kaiser.
Here.
Lucy Langer.
Present.
Sarah Love.
Here.
Chris Pinzon.
Present.
And David Sanger.
Hi. Here.
Wonderful. Thank you so much.
So just to clarify, we're missing Lucy Langer and Katie Schnabe.
We're missing Katie and Adrian Irwin. And with that, we have a quorum of 9.
Excellent. Great. Thank you so much. You have slides up?
Not quite yet. Let's give everybody an opportunity for conflict of interest.
Oh, yes, certainly. Anybody want to declare a conflict of interest today or any day?
All right, and
Hearing none.
a big thank you to those of you who filled out your conflict of interest forms. We'll be reviewing those. I looked them over briefly and appreciate everyone's attention to that detail. And I have the slides. If you could make me a presenter.
So I promoted you to panelist, but you're still in the attendees room.
Okay, try again.
Okay.
It's just traffic was bad and have as much time to get ready as we can for. So I'm going to share screen.
Liz, I promoted you to panelist.
Liz is still getting set up here, so I'll present the slides. All right, so just reviewing our purpose and scope this morning, OHA has set a goal to eliminate health inequities by 2030, more than halfway there. Purpose is to make coverage recommendations for the Oregon Health Plan. Those decisions will affect over 1 million OHP members, and they will affect people's families, caregivers, and providers as well. So a lot of Oregonians affected by the decisions we're going to discuss today. And we won't be making any decisions about individual care. The decisions will be about coverage of benefits and medical necessity policy for the Oregon Health Plan. We do not have any public verbal comment today, though there were some written comments posted on our meetings page on our website, and I would draw your attention to those. Decisions made this morning and early afternoon will not be final unless approved by HERC. In most cases, they will be reviewed this afternoon. Our general considerations around medical necessity and creation of the prioritized list are based on the assessment of the balance of benefits and harms, patient values and preferences, stewardship of public resources, and the nature of Oregon's healthcare delivery system. And those are informed, of course, by our scientific evidence, as well as testimony and expert opinion that you'll be hearing about more this morning. If you're a member, please stay on camera as much as you can. We understand you may need to go off, but please direct message Daphne when stepping away or coming back so we can track a quorum. And also, if there are any logistical issues, again, Daphne's there to help you. Votes will be by roll call. Again, we'll just call the roll. You just go call the roll for us on that. And speak up or raise your hand rather than using the chat. We want to just keep one discussion so we don't have to be monitoring so many places and everything. All the discussion is happening in one place. Nobody offering verbal testimony. Anyone else, if you have difficulty hearing or any logistical difficulties, please ask questions of Daphne through the Q&A. I don't even think you have to say who you're asking, just put it in the Q&A and we'll do our best to address it. chat and Q&A are part of the public record, and the meeting is being recorded and will be posted online. If it's something that can't be addressed during the meeting, please email us at info@oha.oregon.gov, and we will get back to you as soon as we are able. So that is introductory slides.
Would you like to move into a legislative update?
Yeah, we can do that. We can do the minutes after that, I guess, yeah. So, yeah, I got a couple updates, actually. Legislatively, there will be a hearing on a couple of bills related to our benefit update project, currently scheduled for next Thursday in the House Behavioral Health and Healthcare Committee. We've also got several bills in process that amount to coverage mandates for OHP, specifically around continuous glucose monitors, coronary artery calcium scoring screening, and there's one other biomarkers testing. There's a bill that's actually up this afternoon regarding biomarkers testing. So we'll be watching to see what happens with those and how they affect our work. In addition, I wanted to talk about the retreat. And the retreat is coming up on April 18th, which is Good Friday. Apologies to everyone. It will be in Portland. We're still trying to decide which building, so watch your emails for information. We had hoped to have it here, but the building is closed on Friday. So, and that was the best day that worked and we pulled. So looking forward to seeing, I think we have about 25 people coming in person, plus some able to come online. So it should be a really great day. We're going to kind of focus the day around some of the bigger picture issues we've been addressing with making decisions when the evidence isn't great. Isn't what we'd like to answer all our questions. And we'll also have an update from Claire Pierce-Robel, who is our new Health Policy and Analytics Division Director. She comes to us from the DC area. She's got experience with the federal government, so she'll have some insights that I think we'll all be wanting to hear. Of course, we don't know what those will be because things are changing by the day. So looking forward to that. We'll also have some people from our Health Analytics Division to address some of the questions we've gotten about the use of claims data and other data that OHA has access to inform our decisions. So all that should be interesting and help us think about how we make decisions. It'll also just be a great time to get a larger group of people together in person. I have really good memories of the last one, which was just out of lockdown. We had a great day there. Any other staff updates? Oh yes, we had a listening session.
Yeah, so we had a listening session in February, and we heard from several folks about a request to look at applied behavioral analysis for conditions other than autism. They spoke about multiple conditions that they felt that ABA would be effective for, but the ask that they specifically wanted was for the HERC to look at ABA for intellectual and developmental disabilities. So HERC staff have been working internally on the best next steps there, and this is a pretty large topic, so we'll probably not be taking it on until later in the year. And if anyone has any input or any thoughts on that, please let us know, and we'll keep you updated on how that's going. And then also just for your situational awareness, OHAP, our Oral Health Advisory Panel yesterday, you'll be seeing all of their topics coming in May. They passed the general dental benefits update project proposal as well as for TMJ.
If I might add, we are having another listening session on 3/31, and we're in the process of agenda settings. Very excited about that. We've got some good topics. Thank you.
I think that is all the updates I need to provide. What's that? Oh, hiring, yes, this is the best update. So I'm pleased to announce that Dr. Heidi Gullett will be joining our staff as medical director along with Ariel half-time starting April 1st. So she will be able to join us at the retreat. Not sure if she'll be in person or not yet. But she did a residency at OHSU, master's at Portland State. She lives in the Cleveland, Ohio area and will be working remotely from there. But she has experience as in academic medicine as well as public health, leading a lot of the COVID effort there in Cuyahoga County and working as a clinician at a federally qualified health center. So we're very, very pleased to get somebody with a breadth of experience, and we were very impressed. Can't wait to have her on the team in just a week and a half, I guess. So very much looking forward to that. Is that at all?
Just making sure I understand, so the retreat will no longer be in Wilsonville, it will be in Portland.
Yes, it will either be at the 5 Oak building in Southwest Portland or at the Portland State Office building in there at Oregon Street near the convention center.
Okay.
And we'll get parking information to all that logistical information down there for those who are coming.
Okay, great, and the only other thing was to do it open.
Yeah, she's
Sorry. Okay, then we'll go to minutes. If anybody has had a chance to read the minutes, and any questions, corrections, I would entertain a motion to approve those.
I motion to approve.
Thank you, Chris.
I'll second.
Thank you, Sarah. All in favor, say aye.
Aye.
Aye. Do you want that in the chat?
And then, so now how should we do this? Well,
Yeah, Jessica, could you call the roll, please?
One moment. Antoinette Iowaki.
Aye.
Brian Duty.
Aye.
Aye.
Mary Ongrave.
Aye.
Holly Jo Hodges.
aye.
Max Kaiser.
Aye.
Lucy Langer.
Aye.
Sarah Love.
Aye.
Chris Pinzon.
Aye.
David Sagner.
Aye.
Motion carries.
Is that us? Okay, great. All right, Ariel, we'll move into straightforward and consent agenda.
Thank you. The first item is our usual consent table. There's a bunch of E&T things on here because we were working with our E&T experts on the DUP process, as well as just other general issues. Did anyone want to discuss any of these recommended changes in any detail or have any questions about any of them?
And again, we're on page 102 of the public packet.
Oh, thank you. Jessica or Daphne, do you mind calling out the page number of the public packet?
I'm happy to. Thank you for the reminder.
Thank you.
Thank you.
There are no questions. We can go on to the straightforward guideline note changes. The first is our continuous glucose monitoring guideline. There are, this came to us from a CCO who we were talking about, we would not pay for retrospective continuous glucose monitoring, and that apparently is not something that is determinable. So we will, the recommendation is just to strike a clause in there. And then.
In other words, there's not separate CPT codes.
There's not separate CPT
They're all the
codes.
same.
You would have to actually contact the provider and get information and et cetera. The second one is just adding one diagnosis code to our current guideline. Any questions about any of those? The third is stereotactic body radiation code correction. So this is a very focused form of radiation We had a very extensive discussion about this in October, and HERC added coverage for oligometastatic disease with certain conditions in the guideline. However, we didn't add all of the lines that would have appropriate diagnoses. So it's just adding a whole bunch of lines as well as adding the expert codes to those lines, and it would still be guided by the current guideline. Any concerns or questions about
Just confirming the coverage we already discussed.
precisely, yeah.
So do we need to approve those three? So I entertain a motion to accept the consent agenda as presented.
Motion approved.
Thank you, Max.
Second.
Thank you, Brian. We'll do roll call again.
All right. Antoinette Iowaki,
For.
Brian Duty,
Aye.
Marianne Grave,
Aye.
Holly Jo Hodges,
Aye.
Max Kaiser,
Aye.
Lucy Langer,
Aye.
Sarah Love,
Aye.
Chris Pinzon,
Sorry, aye.
David Sagner.
Yes.
Okay, sounds unanimous.
Great, thank you. All right, Ariel, new codes.
Yeah, so just to remind you all, CMS is now releasing HIT picks on a quarterly basis.
That's page 111. Thank you.
Thank you. So we had, of the codes that would apply to the prioritized list, there were about 5. One of them is straightforward. It's an infectious disease test that was recommended for the diagnostic procedures file. The other 4 needed a little bit of evidence review. The first is a simulation angiogram. So this is a simulation or sort of a pretend trial before radioembolization of tumors. It's a training tool that uses a model to mimic the process. It appears to be more about a teaching tool rather than a therapeutic intervention, and so it's not something that we can cover. So the recommendation is to place an excluded services guideline E2 as not a therapeutic intervention. The next is non-thermal transbronchial ablation of lung tumors. This is where you use a pulse electric field that makes a very strong electrical field around the catheter that is used to sort of destroy the cells of the tumor. Other forms of ablation of lung lesions use thermal energy, such as microwave ablation, cryo, which would be cold, radio frequency ablation, etc. So this is does not use temperature, it doesn't create heat or cold. There is no human studies available for endobronchial treatment based on a review from 2023. I did find 3 case studies or case series that were published in 2024 with 1, 6, and 17 patients. Another study I found was the protocol for a clinical trial, and when I went to clinicaltrials.gov, there do appear to be 2 clinical trials that are in progress on this technology. So it appears to be, the summary is basically it's experimental. There's only a couple of case series published to date. There are larger trials planned or underway, so we should get better data on this at some point. So, but the recommendation is to put an excluded services guideline E2 until we get, and if and when we get better data from these planned trials. And then there was software measurement of cardiac measurements from CT data. So this is using an artificial intelligence enabled software where you would take a CT scan and come up with various measurements of heart function. There was a study published in 2024 with 316 patients that looked at this technology, and they said it was feasible. So obviously not a, interesting, but not a fully studied technology. And additionally, we've traditionally said that computer manipulation of previously acquired radiology study data is excluded. And since this is sort of extra step, plus this hasn't even really been studied to see whether it's effective, the recommendation is excluded services guideline 2. And then the last of the codes to discuss is 3D bone imaging from MRI data. So generally for bony structures, you would use a CT scan. MRI is better for soft tissue. CT scans do involve radiation exposure and frequently need to have contrast, which is a substance that the patient would need to have injected. There are improvements in MRI scans. This technology has been proposed for when patients either can't undergo CT because of a particular reason, or to sort of streamline things if you already have a MRI data done. There was a review that I found from 2022. Most studies in this review were on cadaveric bone, and they said that it was it's promising, but it has challenges related to data acquisition and accessibility and considered a novel technology. So this also appears to be experimental and is proposed for excluded guideline and services. Any questions about any of the new codes? And as I mentioned earlier, the last one is an infectious disease agent looking for hepatitis C. That's close for diagnostic.
Any discussion, questions about any of those things?
This is Chris. I'm just curious about the AI stuff. Ariel, are you seeing more of that coming through?
There definitely have, this is the first time I've seen it coming in as new code. There's been discussion amongst the sort of the nationwide network of Medicaid medical directors that there's more and more of this coming forward. And yeah, it's definitely a new area with a lot of interest.
Curious, Val and Marcus, are you hearing about? Yeah, so coming our way, but not sure yet.
There's a med topic nomination to look at 10 discrete new AI codes.
So, all right, any other thoughts? Otherwise, I'd entertain a motion to approve these new HCPCS codes as recommended.
Motion to approve.
Second.
Thank you, Chris. Thank you, Lucy. And we'll roll call again.
All right. Antoinette Awachi.
Aye.
Brian Duty.
Aye.
Marianne Grav.
Aye.
Adrian Irwin. Oh, excuse me, they are absent. Max Kaiser.
Aye.
Lucy Langer.
Aye.
Sarah Love.
Aye.
Chris Pinzon.
Aye.
David Sagner.
Aye.
Holly Jo Hodges.
Aye.
Appears unanimous.
All right.
Okay, so we'll move on to previously discussed topics. These 3 topics actually came out of our benefit updates project discussion, but they are more, they're not in the benefit update follow-up because they're sort of a bigger idea or topic. The first one is cholecystectomy for gallbladder polyps.
And that's on page 117.
Thank you. Polyps are little outgrowths. You can see them in many, many organs. Gallbladder polyps can be a sign of cancer that can be precancerous. We talked about this. We were actually talking more about our just general some coverage for cholecystectomy, and this came up. And I was asked to look at what the current management of gallbladder polyps was. There is an updated joint guidelines from the major specialty societies. It was published in 2022. They recommend, if you see this on ultrasound, if it's 10 millimeters or more, you should remove the gallbladder as long as the patient is capable of having surgery. Mainly to make sure that it is not precancerous. If it's a 6 to 9 millimeter lesion, you should have cholecystectomy for certain higher risk groups, which include people over 60, history of primary sclerosing cholangitis, which is an autoimmune disease, Asian ethnicity, or sessile polypoid lesion. And that's a strong recommendation with low to moderate quality evidence. If you have no risk factors and a 6 to 9 millimeter polyp, or your polypoid lesion is 5 millimeters or less, they recommend follow-up ultrasounds at 6 months, 1 year, and 2 year. And if it's 5 millimeters or less and no risk factors, it's a benign lesion and doesn't need any further follow-up. If it's that intermediate phase, either you're high risk and it's less than 5 millimeters, or it's 6 to 9 without any factors, if it does grow to more than 10 millimeters during the monitoring period, then you would qualify to have a gallbladder taken out. And I couldn't find any private payer coverage that would limit the cholecystectomy for this condition. So cholecystectomy is recommended for gallbladder polyps measuring 10 millimeters or larger, or 6 to 9 millimeters with 1 or more risk factors for malignancy. And so the staff recommendation is effective, I apologize, it says 10/1/24, it's 10/1/25, that we would add the diagnosis for, so it's cholesterolosis of the gallbladder is actually how the diagnosis code that's used for this. We would move that to line 55, and then we would modify our current cholecystectomy guideline to include a new section that states cholecystectomy is included on the upper line for the diagnosis when one of the following conditions are met: 10 millimeters or larger polyp, or 6 to 9 millimeters with the 4 criteria that were identified by the specialty organizations. Otherwise, that diagnosis is included on the uncovered line. And then for 1127, this would be a diagnosis that would be moved to the code grouping for that includes all of our reasons for cholecystectomy, with the same guideline essentially. Questions or concerns? And I don't know how you define Asian ethnicity. That was from the specialty organizations.
Self-report.
So either, so A, change we've made in A is we've added either. So A, and then it will be either evidence of inflammation or ultrasound findings, which is, or radiographic.
The A words, we actually did that in our last meeting.
Okay, that's what I thought.
Yeah, that's why it's in purple.
Okay, and then we
Sorry,
added,
we're just trying to keep the,
right,
all of these changes will take effect October 1st, so we're trying to just keep version control.
got it, okay. Version control, I like that. Version 28. It's coming to you soon. Okay, so, got it. I thought those looked familiar. Purple's old, and then the new is in blue.
Yes.
In this, okay, second. Got it. Okay, I've been doing this for years, so this makes perfect sense to me.
So this is Chris. So does B go away? Are we modifying the whole guideline note and we're consolidating A and B, or is it just the A?
So no, if you, on page 119 in purple is what we previously discussed,
Okay.
was a different topic.
Ah, okay.
Yeah, we approved that in January.
Yeah, that was,
Staff have had some problems with version control where we edit in one meeting and then edit again in another meeting, so I'm trying to carry forward with purple words.
yeah. So the purple is previously discussed and approved, and now we're on blue on page 120.
It's true.
Okay, but it's adding to it.
So we're adding coverage in blue.
Okay.
For this, for polyps.
955.
Gallbladder polyps.
Okay, thank you.
Thank you. Other questions, clarity? Again, this makes perfect sense, and most of us have already been approving these when they met these issues. Other thoughts? Mary Ann Graf?
Sorry, I think it does make sense, and we can all think of that one case where it ended up not being a polyp and being something worse. So I think it's completely reasonable.
Super. All right, I'll entertain, do we wait till the end?
It might be easiest to just do all of the previous discussion as a group unless we really get into a debate on one topic, which would be my suggestion.
Which we can.
Which we can.
We'll wait, thank you.
Yeah, so the next topic is a follow-up. We had a very long discussion about Ehlers-Danlos syndrome at several recent meetings.
That's page 122. Thank you.
And at our last meeting, it was pointed out that there's another diagnosis code that's used for hypermobility spectrum disorder. And that was proposed for possibly being treated like Ehlers-Danlos, and staff were directed to look at that. So
I didn't most of this discussion haven't heard of stuff.
it may have happened at her last time.
Oh.
There's discussion of both.
Okay, yeah, all right.
So Ehlers-Danlos syndrome, we added coverage for. This is a condition that is highly related but different. The ICD-10 code, the wording is hypermobility syndrome. However, we had 17 public comments, and many people noted that the term used by patients and providers is hypermobility spectrum disorder. So when I talk about hypermobility syndrome, I mean the same thing. It's hypermobility syndrome or hypermobility spectrum disorder. One is the sort of code description, and the other would be the sort of description in use. Hypermobility syndrome is when you have certain joints or other areas that have more movement than you would expect, but you don't meet criteria for Ehlers-Danlos syndrome specifically. When we talked about this for Ehlers-Danlos, there were criteria for diagnosing Ehlers-Danlos, but you wouldn't meet those criteria for hypermobility syndrome. There are some criteria for diagnosis of hypermobility syndrome. It's essentially you need 5 or more points on a scale called the Baton score, or 6 if you're a child. And then the treatments that are recommended for hypermobility syndrome disorder are similar to those for EDS. So the paper that lays out sort of the criteria for diagnosis was published by Atwell et al. In 2021. So they use the Baton score, again, affirmative answer of 2 or more out of 5 questions, being very sensitive. And they talk about the different types of joints and different degrees of laxity. Again, we had quite a bit of public comment on this topic.
And those can be found on page 126.
And in general, the public comment was all in support of adding coverage for Ehlers-Danlos, which is one of the options that staff will talk about in just a second, as well as that concern about the terminology used. There were papers submitted. They were mostly general reviews. And then one was a early laboratory study about a biomarker as a possible test for Ehlers-Danlos and hypermobility spectrum disorder. So in summary, this code M35.7, which is hypermobility syndrome, specifically in the coding manuals, it's not to be used for EDS. It's used in practice to code for hypermobility spectrum disorder. The proposed diagnostic criteria are in Atwell 2021. And the treatments that are proposed for this condition are similar to EDS. So there are 2 options proposed by staff. The first is to make no change, somewhat because this is a much less defined condition. The second option, which was overwhelmingly preferred by our commenters, was to add the hypermobility syndrome diagnosis to the same diffuse disease of the connective tissue line that we had moved Ehlers-Danlos to, and then modify our new guideline for Ehlers-Danlos to include hypermobility syndrome or hypermobility spectrum disorder. And it would include a clause that hypermobility syndrome, also known as hypermobility spectrum disorder, is included on that line when you meet all of the following criteria. A Baton hypermobility score greater than or equal to 5 out of 9 points in adults, 6 out of 9 points in children, and 4 out of 9 points in adults over age 50. And one or more secondary musculoskeletal manifestation, including post-traumatic symptoms, pain, altered proprioception, kyphosis, scoliosis, and joint misalignment, and do not meet the 2017 International Classification for Diagnosis of Ehlers-Danlos syndrome. And then adding references to hypermobility syndrome where it refers to EDS in the treatment section. Discussion.
Hi, this is Mary. I think it's a good discussion, and I know it's becoming a very politicized area. I have ongoing concern based on consistent patterns of chart reviews. We see that the diagnosis is not substantiated, and that it's kind of become a niche diagnosis and concern of over medicalization. And I'm really concerned that there's literature that supports this. So those are my thoughts.
Mary, can I just ask, clarifying, do you mean that it's, there's not a clear definition for the diagnosis? There's not a clear set of, is it a definition issue for diagnosis?
Or a documentation issue?
Or is it, is there documentation?
I would say all of the above. People are getting the diagnosis, patients are getting the diagnosis, and you read the chart notes, and there'll be requests for various services, wheelchairs, what we would consider very high-risk medications for these conditions that could potentially lead to weakness and falls. You read the notes, like my cousin always said, I have hypermobile joints, therefore. And the patients receive, and this is a consistent pattern, and it's nationwide and it's worldwide. There was an article this week, interesting, it's a light article, but it's interesting about over medicalization in the Wall Street Journal. But I'm not aware of any medical literature that supports this, unless there's something I'm completely missing, and we're just seeing really concerning chart notes.
I'd say I have similar experiences with, there doesn't seem to be consistent criteria, nor is it consistently applied. But I think I had similar concerns with Ehlers-Danlos. That one does have consistent criteria, but rarely do I see it consistently applied. So this seems even more amorphous.
So even when there is consistent criteria, it's not consistently applied to get to a diagnosis.
I can think of one chart maybe I've ever seen that actually applied. The Ehlers-Danlos one, because that one has specific, relatively well-known criteria. I think I can think of a chart for hypermobile version where they actually charted these are the criteria, this person meets these. Rather, I have more amorphous kind of subjective reporting where I see it diagnosed, or it's just the person says they have it, so it gets added to a chart. That happens frequently, and then they kind of put a note that says, well, they told me this, and I'm not really sure there's all these questions, but that diagnosis is still put in the chart. So for these, which is even less defined, I have even more concern.
I agree with Max, and I think there's risk of harm. And the risk of harm that we're consistently seeing is patients receiving treatments that don't appear appropriate, high risk, 21-year-olds ending up in wheelchairs, group 3 wheelchair requests, which is horrible, right? Falls. And then also, I don't know if every CCO is having this, but I suspect they are, that we're having neurologists, rheumatologists decline to accept referrals because there's the diagnosis don't appear substantiated and overdiagnosis, and it's just it's so I that confers to me a risk of not receiving appropriate diagnosis. So I think this is not an issue that's without potential for harm.
Yeah, I've seen it.
Oh, sorry, Sarah, I saw you nodding your head. Did you have something to add?
No, nothing to add. Just a lot of people do self-report.
And and just to remind everybody, we did receive a number of written comments on this, and those are in the issue. So, but there are patients who are very concerned about this and having a lot of trouble accessing the care they feel they need. Just want to make sure that's a part of the discussion.
Yeah, there's lots and lots. Lots of things to read there.
This is
Anybody
Chris.
else? Yes, Chris, please.
What I was seeing is that there is an attempt here to actually lay down some criteria and putting as a guide. Perhaps there is, I think the risk for harm is real, and I'm just wondering, I was seeing that adding the criteria might inform the providers and the patients to know what to look for and what to advocate for in their charts to receive that treatment, because it looked like there was some clear guidelines that they could use and some measurements that are added here to improve the reporting, and the guideline that may not. So I guess what I'm looking at is there's usually self-report, but then it's usually part of the role of providers to substantiate, right? So if we're putting it out there as code guidelines for the coverage, do you think there'd be an uptake in utilization of these tools to improve the substantiation for and differentiate those that meet the criteria and don't? I guess it's kind of a general question, but Mary, I'm wondering if you think that might help.
I don't know if that would help. I'm worried about, I'm trying to think of how to really carefully phrase this. I'm worried about giving substantiation to, I don't know. I don't know if I can answer that question. Right now what we're seeing is apparently everything meets the criteria, and it is definitely a practice among specific providers where this is, and they're giving scores, right? So what we're seeing now when I think about this, they're giving scores that do not appear substantiated based on the exam notes or the history and physical that we're seeing. So I don't know if this would make a difference or give more credence to misdiagnosing. Like, I said they have this, therefore they have. So I don't know. We'd probably have to get a neurologist or rheumatologist to speak to this. And when we've tried that before at meetings, they didn't want to participate. I think because this becomes such a politicized issue that no one wants to discuss it publicly. So I don't know if others have different thoughts about that.
I'd be cautious because there are other, things like MCAS, which has actually a laboratory diagnosis. I often see that diagnosis on a chart, even with notes that says we did the test at the appropriate time and it's still negative, yet the diagnosis persists. So I would be cautious even if adding that would add to it. And I'm sort of thinking of it as for the evidence-based committee, right? And there's not a ton of evidence both supporting this diagnosis and treatment, how it aligns. And it sounds like even that, if I understood right, the suggested criteria doesn't seem to represent the experience of the patient population based on what was reported in the public comments. That was kind of what I gleaned from that. They said it didn't kind of encapsulate their full experience.
Well, they were saying it is a highly variable and every person has a different set of symptoms. There's some patterns. It's distinct from hypermobile EDS, but it's not less severe. Those are some of the themes I saw. And so it just seemed very difficult to know what specifically you would do differently for this.
The diagnostic criteria is just flexibility of certain joints, right? That's what Brighton score is, which doesn't seem to encapsulate the experience that they're describing.
There was chronic pain, there was, a lot of different symptoms discussed.
So I'm not sure how helpful and representative that is of the issue and what we're hearing you need to help with. So I'm not sure that criteria would be incredibly effective either. And I think we have to, and it's not a fun acceptance, but science progresses at a different pace than guidelines do, right? So we're always going to lag a little bit with our understanding and based on, we get new diagnoses, there's early information or new treatments, and those develop, then they show that they're reliable or repeatable or effective in terms of treatment. And I'm hoping we're at the early stage in this develops and we get a better idea and narrow it down now, but it doesn't seem like we're at our standard level of evidence to substantiate a diagnosis.
So
just to play devil's that, or not devil's advocate
is that
really,
line?
but so in 2027, we will have to have this diagnosis be covered, or at least office visits and evaluation. Would it be helpful to have the guideline change then to include these criteria at that point? Or would you like to just kind of keep it as a diagnosis that's just in the evaluation and management grouping?
I think it's closer to 2027. Frankly, because I think these things change a lot in 2 years. We could have a very different either understanding or public sentiment about it or approach to it. As of now, actually, I probably said no as of now, because I don't think that criteria seems to cover what they're discussing. To me, that's more a problem of we're not capturing the things they actually need help with, which we can get through comorbidities, and that's a systemic communication issue, not a we need to add a diagnosis issue. So there's clearly an unmet need. I don't think we answer it with this. And I'm not sure we can answer it with that diagnostic criteria either.
Anybody else online? Lucy, David? Thoughts?
This is Chris. I'm sensitive to the risk of harm that I'm hearing Mary say, and I'm just wondering, we often will put kind of guide rails or like a follow-up or some review to kind of check for that harm. If it's pain management, is there any way to link it to some of those guidelines or set like a frequency for review
So let me
from the provider to look at that care plan or those aspects of their
yeah, so just so you
plans?
understand,
It is so variable.
when folks like this have certain things like back pain or neck pain, that would then fall onto a covered line and allow them to then have access to the services under guideline note 56, which includes chiropractic and massage and PT and acupuncture. And so, these things are already being done currently for funded comorbid conditions associated with this condition. So those things are already being done and I think widely taken advantage of and used and utilized and helping people.
Yeah.
As I
That's the barrier that I heard at the first public comment, was that they were just not even indoor.
Yeah, the thing that I've heard asked for that would not be covered would be like physical therapy to strengthen muscles to prevent injury. Because someone has this condition which puts them at risk, and that's something we reviewed for hypermobile EDS and did not find evidence that it prevented anything. There wasn't a lot of evidence, but that's.
And as a general principle, the Oregon Health Plan doesn't do things to prevent a possible thing like a skin ulcer or it's written in OAR. There's lots of things that we don't do as preventing a not exactly inevitable outcome.
So the proposal, just make sure I understand. So we're talking about making the criteria more restrictive so that we're no longer over-diagnosing people with a questionable condition, this hypermobility syndrome, which might or might not, but it's just very loosely defined. And we're going to restrict to some extent the coverage for that condition because we're saying it's not the same as Ehlers-Danlos syndrome. Am I understanding that?
Is that what option 2 gives us?
Option 2 gives the current standard guideline criteria, which I was hearing from Max may or may not actually be something that is useful.
But I
think there's
option 1 would not change.
There's two options, David, right now that we need to look at, and option 1 is to leave it like it is, which is non-funded, which does come with, like we talked about, when those other funded comorbid conditions exist, they get treated, or moving to option 2. So I think if we want to take a look at page 124,
The others are, right, that's the screen that shows the list of people.
So if we do move it from the line where it's no minimally effective treatments to something where it would be a covered condition, what are the treatments? Because when I'm treating and looking at this, I go from more of a preventative standpoint of look at physical therapy, but given our OARs, we can't do that. So we would be treating with what?
So currently, the line that's being proposed does not have physical therapy because we didn't find any evidence of effectiveness for Ehlers-Danlos. And since this is an even less defined disease, I don't think you're gonna find anything. They would have access to medication subject to PA, although they do now, as long as they're not PA, like ibuprofen or antidepressant or something that we don't PA. Office visits, education, DME, but that would require them to qualify for the DME through the rules. So like a wheelchair, you need to qualify for.
And there'd probably be other comorbid diagnoses that would be necessary as well, right? I don't know.
I mean, that should be documented, if a patient has multiple conditions, that should be taken into account. So on that line would just be, I guess medications that do have PA would have to have, they couldn't have a not funded condition just stop. They would have to go down to some type of way to get coverage. Would be the one major change.
It's still have to meet that PA criteria,
Yeah.
nothing's FDA approved. Each individual CCO can do what they want, but it makes it unlikely that if you're PAing something, if you're not PAing it, then it's the same as now. So probably a small percentage that would go through that, require PA, and then get approved by the PA for a non-FDA approved condition.
Yeah, specialty visits, but they should at least have an evaluation visit covered at this point. Essentially the coverage is very similar to what it is now and uncovered line, except for possibly the PA medications and maybe a little bit easier access to some DME. If it's, kind of a DME that's doesn't really have requirements like a split maybe.
Okay.
But we don't even PA things below.
Right, yeah, I think they should have that
Tech-
now.
Technically, DME still requires some level one diagnosis.
Yeah, I'm just thinking if you don't PA like
Okay.
a cock-up wrist splint or something that, because it's not expensive, they're probably already being able to access that.
Our website.
Yeah,
Other thoughts, discussion, suggestions?
Can you summarize again, just to make sure I'm really clear, the difference between option 1 and option 2 in terms of like which is more liberal and which is more restrictive, because it's confusing with the
Well, I think it's confusing because it is confusing, David,
Yeah.
because I think there is some risk in operationalizing option 2 in actually limiting things. And whereas right now with option 1, folks may be getting again through the other conditions and symptoms that come with these conditions, they are getting treatment and care. Whereas if we really try to pin down this diagnosis, many fewer people may actually have the diagnosis and then fall elsewhere.
And I guess you could have a third option where you move the diagnosis to a covered line, which wouldn't really effectively change in reality things without changing the guideline. That you could, we could modify and do that as a third choice.
Well, if you did that, though, medication and medical equipment covered for that diagnosis, there'd be no guideline to.
Yeah, be much bigger.
Yeah, so in 2027, no matter what we do now, this diagnosis will be covered. We have to cover all diagnoses. And it would be
But for primary care office visits.
primary care office visits, medications, diagnostic testing, and DME that they qualify under DME rules. And
Which in all honesty, most folks are getting now.
yes.
We don't deny conditions in a PCP office, especially when often this is not gonna be the only thing they're being seen for.
Right, essentially, we think that the 2027 change for a lot of these diagnoses is really no change. It's just acknowledging that we do actually provide some care. So option one would be kind of delaying official coverage until 2027. Option two would be adding official quote unquote coverage in October with the guideline. And this option three that we could think about would just be adding coverage in October without a guideline.
I think, and the guideline, function of the guideline would be to limit it, or require those charts to support the diagnosis.
Which again goes back to what we talked about earlier, that without clear diagnostic criteria, there's a lot of folks with walking around with this diagnosis who may even be getting many things with lots of side effects that they didn't need. Did that help, David?
Yeah, thank you.
Good.
I'm sorry that I'm just, it's.
Oh, no,
No.
we're all in the
Baby
same
steps.
boat. Or the more we talk about this, I sometimes think the more confusing it gets.
It's confusing.
Brian, yeah, Brian,
No,
just
I'm-
acknowledging that it's.
yeah, I'm just acknowledging. Yeah, I mean, I don't know that I have any great insight into it because, yeah, it's hard to kind of wrap my mind around a little bit. So,
This is Chris. I kind of like the idea of moving the option 2 number 1, but then you have information down at the very bottom for 1/1/2027. It would be placed in the evaluation. I'm just wondering if that's where we're going, is that's what you're trying to delay, but it also defines what would be available to them in pretty simple terms, because I think I read somewhere that part of the challenge with this M35.7 is that it's specifically not identifies or excludes EDS from the diagnosis. But I
Yes.
think it addresses a lot of the public comment for recognition that it's a problem. I think that would be like some happy medium, but maybe not adopting the guidelines until we actually have things that are presented to restrict it. I don't know if there's anything to add there to put some guardrails on the potential risk for harm related to that.
Well, Chris, I think the guardrails are by giving the definition of what they have to meet to make the diagnosis.
Yeah. Oh, okay. So then the guideline needs to go with it.
That's the actual guardrail, I think.
But then that's confusing to me because the guideline was for EDS, and if M35.7 excludes EDS, then it wouldn't match.
Well, so the guideline would be modified for both. It would, in the title would have both conditions, and then it would
So,
have a paragraph about EDS and a paragraph about.
The blue on page 125.
Yeah,
Okay.
so the
We're talking
proposed guideline
For
got
mobility,
changes.
I saw. Okay. I see. Okay, I'm back to square one. I'm gonna defer to the experts. I'm trying to understand.
So we're essentially upgrading hypermobility syndrome to the same status as EDS.
It's got a limited, it's, if you look at that note 411/2027, it's more limited. Am I understanding that correctly?
So the guideline essentially says you have to meet these diagnostic criteria. And then it just says that things that happen, like sprains, et cetera, should be treated. And we need to look out for the comorbidities and.
It's trying to be more specific and not use the more undefined code.
Well, it's still pretty vague, right? I mean, this hypermobility syndrome is a lot more vague criteria than the criteria for EDS,
Mhm.
right?
Yeah.
Yes.
So that's the problem, is that we're potentially going to start coverage for, as Mary was saying, we're going to start coverage for something that's very poorly defined.
Yeah. And so coverage is already provided based on the symptoms it generates or the specific problems it creates.
Right, but there's a difference between a problem by problem coverage versus a global diagnosis
Yeah.
coverage.
Yeah.
But just to throw out there that the condition, that diagnosis code will be covered officially in 2027.
And so
So if it's covered officially, then why are we having this discussion if it's already, we're just talking about what are the stakes here?
Stakeholders felt that this diagnosis that was different than EDS should be officially covered sooner. Because of their unmet needs, and then staff felt that if we were going to cover it, we should define it, which is why the guideline note was modified. You have two options. Yeah, so you have two options. You can do nothing until 2027, and it will just kind of go in the bucket where it kind of is now. It will just be moved over, or we could move it to a covered line and define what we think is the diagnostic criteria now. And in part of this discussion, I think people are struggling with is there's not a lot of differences in all of these options about what actually is. You know, I think what we heard in the public comment, a lot of the pieces that came out in this set of public comments even are things that we can't address, like lack of coordination of care, lack of sort of holistic global care, lack of good pain control options for chronic pain conditions, all those types of things.
So back to our options in front of us. So we have on page 124, option 1 is to make no change in the current placement. Option 2 is to move M35.7 to line 141, remove it from an unfunded line and modify the EDS adopted guideline note to include hypermobility syndrome with the following adjustments on page 125 that would become effective October 1, is that right? October 1 of this year. Any more thoughts, discussions, or a motion to accept one of those?
Motion for option 1. Can I add to that to readdress it as late as functionally possible?
Yeah, we can put a note in, we can address it in the fall of 2026.
Whenever it works for you guys scheduling workload, but I think it's worth considering that different context too, so that's a slightly different discussion.
In waiting for further research and evidence to appear.
Yeah, and it's going to be a funded, whatever term we use, covered in 2027, so I think there is a discussion there. Is it more appropriate to have limits like a guideline note, which actually I think probably limit access for those being asked for public, as opposed to just looking at how it is. Maybe that's
So in a clean, concise way.
Number one, talk about it later.
And staff will put it on our to be circled back to at some point.
So we have a motion for option 1 on the table.
I'll second that.
Wait, can I get, so does option 1 also include, add in the, edits?
It does
of the
not.
criteria?
It does not.
No.
It does not. It does
Not at
What
this
needs to
time.
be said,
It's
what is
basically don't
covered.
do anything.
Okay,
Just leave it how it is now.
okay.
Clarifying question. And did I hear a second? Who was that?
Yes, Lucy.
Lucy, thank you. Seconded, and there's no further discussion. We'll go ahead and do the roll call vote.
All right. Antoinette Awachi,
Aye.
Brian Duty,
Aye.
Mary Ungrave,
Aye.
Adrian's absent. Max Kaiser,
Aye.
Lucy Langer. I'm sorry, Lucy, I didn't hear you.
Aye.
Okay. Sarah Love,
Aye.
Chris Pinzone,
If I abstain, can we still make quorum?
Yes.
Yes.
I'd like to abstain.
all right, and then David Sagner,
Yes.
Holly Jo Hodges.
Yes.
All right. We have near unanimous. I believe the motion passes.
So that was just on the hypermobile EDS.
Yes, we
still
just-
haven't-
We just dealt with that. So now let's do our C, neuralgia paresthetica, and then we'll do A and C
A and
together
C
in one
together.
motion. Thank you very much, you all.
So the next topic is neuralgia paresthetica.
And that's on page 142. Thank you.
This is a condition where there is altered sensation on the outside part of the thigh. It's thought to be caused by an impingement of the lateral femoral cutaneous nerve. Treatment includes lifestyle modifications such as avoiding tight-fitting garments, NSAIDs, tricyclic antidepressants, topical capsaicin, TENS units, physical therapy, and ultrasound guided injections to block the nerve. If these are ineffective, patients may undergo surgical neurolysis or neurectomy, in other words, cutting or destroying of the nerve. Currently, neuralgia paresthetica is on the medical and surgical lines for peripheral nerve disorders that is below the funding line. The injection code for an anesthetic agent into that peripheral nerve is ancillary, meaning it's only covered for a covered condition. The neurectomy code is on the depot balloon line. Evidence: there was a Cochrane review in 2012 for treatment of neuralgia paresthetica. There were no RCTs or quasi-RCTs found. There was a single study of 29 cases that found spontaneous improvement in 69% of cases. There were 4 studies looking at injections that found cure improvement in 83 patients out of a total of 157. Surgical treatments have been found to be beneficial in 88% of 300 cases reported that had decompression, and 94% of the 48 cases treated with neurectomy. And then 97% of patients with iatrogenic or medically caused neuralgia paresthetica completely recovered spontaneously. So the author's conclusion was, in the absence of any published RCTs, the objective evidence is weak. The highest quality evidence from observational studies report high improvement rates with local injection of corticosteroids or surgical interventions. But similar outcomes have been recorded without any intervention in natural history studies. There was an updated systematic review and meta-analysis in 2021. They found 25 observational studies with a total of 670 patients. 12% were treated by injection, 74% by neurolysis, and 14% by neurectomy. Complete pain relief was seen at 85% after neurectomy, 63% after neurolysis, and 22% after injection. And then they noted that there appeared to be multiple treatment options for this condition. So the summary is that this is a condition, although it can spontaneously resolve, it also does have effective treatments that are interventional, but it's a very limited evidence base. It is a rare condition. The staff recommendation is to move to the covered line with the neurectomy procedure. So this would be to add it to the peripheral nerve disorders, or move it from the peripheral nerve disorders uncovered line to the deep open wound line. And I realize this is not a deep open wound. There are a lot of conditions on that line that are just basically repair or surgical issues. Questions, concerns, discussion?
This one's a lot more straightforward. Thank you.
Yes, we wish they all were. If there's no discussion, I guess I would.
Can you entertain a motion to move all with the exception of the hypermobility syndrome?
It would be to
Is that how?
go for the staff recommendations for cholecystectomy for gallbladder polyps and the Morrelsia paresthetica.
Yes, please.
Thank you, Chris. And a second?
I'll second.
Thank you, Sarah. We'll roll call for approving staff recommendations for A and C, cholecystectomy for gallbladder polyps, and Morrelsia paresthetica.
All right. Antoinette Awachi,
Aye.
Brian Duty,
Aye.
Marianne Grev,
Aye.
Max Kaiser,
Aye.
Lucy Langer,
Aye.
Sarah Love,
Aye.
Chris Pinzone,
Aye.
David Sagner,
Yes.
Holly Jo Hodges.
Yes.
It sounds unanimous.
Thank you. Great. We're going to move on to our one new discussion item, which is colon manometric studies. And Marcus Bachhuber did the evidence review, so I'm going to turn things over to him.
Thanks, Ariel.
Before you do, that's on page 146. Thank you.
Thanks, Stephanie. So colon motility studies look at how the large intestine functions. It's in contrast to anorectal motility studies. Those are different, those are covered, those are not what we're talking about today. So colon motility studies involves placement of a pressure-sensitive catheter in the large intestine, usually involving anesthesia or sedation, and the catheter is left in place for about 6 to 24 hours. So for evidence, we found 4 relevant studies. The first 2 were systematic reviews around pediatric uses, one in after repair of anorectal malformations, and one after or in children with Hirschsprung's disease. And so Hirschsprung's disease, as the medical folks may remember from school, is a congenital anomaly where a baby is born missing nerve cells in part of the colon, leads to problems with defecation. The third study was a small study of 18 children that found colonic manometry can help identify neurological colon issues. And the significance of that is that if there's a neurological condition that may not respond to medical treatment, it may require surgery. The fourth was an uncontrolled study in 80 adults with constipation that found it was more able to identify these neurological issues with the same implications. We found 4 guidelines. The first, from the International Working Group for Disorders on Gastrointestinal Motility, was a technical recommendation that the test is the reference standard for colon motility, so not really a clinical recommendation there. We found 2 guidelines from the American Gastroenterological Association from 2013. They had a recommendation based on low quality for use in circumstances where symptoms persist, but also note that the test is really only available in specialized research centers, and the specific clinical role is not well established at this point. The last guideline we found was the American Neurogastroenterology and Motility Society, which provided some specific and highly subspecialized clinical circumstances where the test may be helpful, mostly in children. We found 3 payer policies for these studies. Medicare had no NCD or LCDs, which we could identify. Aetna considered the test medically necessary to guide decision-making for children with refractory issues, and United said that there was insufficient evidence and did not cover it. And I will kick it back over to Ariel.
Great. So in summary, colon manometry has very little evidence of effectiveness, and staff is recommending continued non-coverage. It seems like the best evidence is for very certain rare conditions in children, and they could be covered through the EPSDT exception process. So the recommendation is to update the date of last review in our excluded guideline 2. Max, you don't agree?
No, I'm just debating, is it worth making an incredibly specific guideline note for refractory kids where there's
Yeah,
a
probably
question of,
not.
right,
I
that's,
mean, this
yeah.
is the issue is that
It's
the only
not-
places that wanna do this are places who have the technology to do it, Seattle.
Yeah, and we've gotten requests for this, not incredibly common, but it has been. I think it might have been adult, I think mostly this have been kind of kids, adolescent populations, refractory constipation. And I think we've kind of improved in those situations. Once they've gone through.
Yeah, I'd love to know
extensive-
if it then changes things.
Right, once they've gone through
Love to follow
extensive
up to
work.
know if.
Or we've also
And it's
said,
a pretty extensive study, they have to like
It takes
anesthetize the
two,
kid.
it takes 2 days.
we've also said, we really need to go through this whole diagnostic pathway before it's very too, so it's pretty specific. So I was just waiting if that was
It just
worth it or
sounds
not.
really uncomfortable too, to have a catheter in
Very,
place for like.
very interventional, extensive. Yeah,
Which is
general
another-
anesthesia is not a benign procedure.
Another thought of would be helpful to have a guideline not to limit it because it is pretty significant. I was just weighing it in my head, I'm not really sure, I think it's so rare, probably not, but I think that's what we're talking about.
I don't know what a guideline would say.
I mean, it's super like in kids, once they've gone through all this work out.
Yeah, once
And
they've
you have
gone
a
through-
consideration for surgery, like, yeah, it would be. That, I think that's part of it too, is it's varied enough that it would have to be ridiculously specific. It's
Yeah.
probably not.
Probably not worth it.
Yep.
Pediatricians in there.
We'll have Mark this afternoon.
Yeah. Mary, what are your thoughts? Do you see requests for this?
You know, I don't think I have. I don't think I've seen. Oh, no, do you know what? You're right. You're right. I'm sorry. They go to UW and we approve it.
So the American Neurogastroenterology Motility Society does have some specific criteria. So severe constipation, unresponsive to medical therapy, to confirm chronic megacolon or megarectum, clarify the pathophysiology of persistent symptoms when kids with Hirschsprung's after surgery, and evaluate the function of a diverted colon before possible closure of a diverting ostomy. Predict the response of antegrade enemas?
You know, I think that makes sense. And the ones that I'm thinking that we see it's always like the legacy or OHSU groups who've done these huge workups on kids, usually with complex comorbid conditions, and then request the test and then request it. Yeah, but that completely makes sense.
Yeah, but do you think we need a guideline note, Mary, or do we just trust our super quadruply boarded specialists to take care
Okay,
of
I'm
this?
trying to think of how this is configured because for some reason these go to medical director. Maybe it's because they're non-par.
And because they're excluded.
And out of state.
And out of
Yeah, so
state.
Yeah,
Although,
they would always
yeah.
come to us because the only people that do them.
You're right.
Are gonna be out of state. It's UW and Cincinnati and Mayo or something. There's not very.
I mean, I guess the risk of having it as excluded is if someone doesn't understand that there's going to be some situations where you need to approve it by exception in a sick kiddo with a lot of comorbid conditions and who's, been kind of extensively worked up by a specialist. So I guess to me, that would be the risk that there's going to be confusion at a CCO level, that kid might not get the study, but maybe I'm missing something.
Have an EPSDT
Yeah,
review.
EPSDT makes
That's
all that.
true. That's true.
Yeah, under 21, they all have to go to medical director review.
That's true. That's true. Good point.
I don't think ours have had megacolons or megarectums, the couple I've seen. So if I'm remembering correctly, I think that would be the restrict from the ones we approved.
Which I don't think is our intent. Again,
No, that's why now I'm like, I think again, that might be a bad
I think we
idea.
just
Yeah.
trust our quadruple.
I think that might be a bad
colleagues to do the
Yeah.
right thing.
Yeah.
Mary, you good with that?
I am good with that.
Excellent, thank you. Entertain a motion to accept staff recommendation for continued non-coverage.
Motion to approve.
Thank you, Max.
And I'll second Mary.
Mary seconds. we'll run the list again, please.
Okay. Antoinette Awachi,
Aye.
Brian Duty,
Aye.
Marianne Grav,
Aye.
Max Kaiser,
Aye.
Lucy Langer,
Aye.
Sarah Love,
Aye.
Chris Pinzone,
Aye.
David Sagner,
Yes.
Holly Joe Hodges.
Yes.
It appears unanimous.
All right, Ariel, take us on to the 2026 biennial review.
Great.
And we
So-
do have a break coming up, people, so hold on.
Yeah, and you are on schedule.
I know.
You're 2 minutes early.
I'm driving
So
this, man. I mean,
the first two topics that are coming to you are from the benefit update project. Staff have identified a couple of lines that are really pretty non-functional below the funding line, and so we are recommending just deletion of these non-functional lines. The first is fingertip avulsion, so this would be
And that's
when-
on page 151.
This is just when a small portion of the top of the finger is completely removed from some trauma generally. There are two lines, line 206, which is the deep open wound line, and line 603, which is called fingertip avulsion, are completely redundant. They have all the same codes. So it's a non-functional lower line. So the recommendation is for October to strike through, and then for the biennial review starting January 1st, 2026, just delete the lower line. All these codes pair, and there's doesn't seem to be a function. Anyone concerned about that or want to object to that? That's pretty straightforward. The second is a very similar condition. There's two lines for foreign body in the GI tract. So foreign bodies are actually pretty common, especially in children. They swallow all kinds of things.
Page 153.
Many of these are harmless. You just need, kids swallow coins and things, and we just make sure they eventually come out the other end. And basically, you might need an office visit or an ER visit or something for the parent concern, and then kind of reassurance and instruction. There are some things that are possibly dangerous. Batteries being one of the really big ones in kids, sharp objects, magnets, things that have not passed out of the esophagus in 24 hours. They've been in the stomach for 3 to 4 weeks. There are conditions where there's like a large, hair collection or something from kids or other things that are kind of stuck in the stomach. Things that are really large that we don't think will pass, magnets that can be reached by an endoscope. And then if the person who has gotten this foreign body doesn't appear to have other symptoms like an overdose, you worry that there's something in whatever they've swallowed that could be causing problems. Or if there is obvious signs of perforation, obstruction, other things that would make this to be a medical issue. And those are kind of the common indications for when we would actually intervene in a ingested object. So currently, all of these diagnoses and all but I believe one of the procedures are on two lines. One is line 41, which includes hazardous foreign bodies in the GI tract with risk of perforation or obstruction, and then line 513, which is foreign body in the GI tract without risk of perforation or obstruction. These two lines were created, I believe, back during the ICD-10 conversion 15 years ago, to basically make it really clear when you didn't need to intervene. And there is a guideline that says that all those diagnoses are on the upper line for sharp objects greater than 2 inches, magnets, button batteries, other things that could cause perforation or obstruction. All private payers cover endoscopies, for all foreign bodies when there's any concern for obstruction, perforation, or other complication. So the staff recommendation is there is one specific code that is on only on the lower line, which is a small intestinal endoscopy. Add that to the upper line, and then strike through the lower line for 1125, delete it for 1126. And then the current guideline note works perfectly well if we just strike it basically says, you know, medical man, you only get a procedure if you've got these other things going on. Otherwise, it would just be medical management. So again, kind of non-functional lower line, we have a guideline about when we would want someone to have an intervention. Questions or concerns about that? So, you always confuse me when you use the term lower. Unfunded. There's a funded and an unfunded line.
And now we're gonna just become funded.
Right, with the guideline that still says you need to have some sort of a risk of perforation or obstruction. Good. I like it lower, I like it lesser.
See the confusion.
So funded and unfunded line, but all of the procedures and diagnosis codes pair except for one random code.
And it's all gonna go to the funded
Line, and that guideline will just be on the one guideline, and it'll just say basically what it says now. Yeah, like you can get an endoscopy if you're worried for some reason. And then obviously if there's something bigger, like it's already perforated, that's a totally different diagnosis, and they get a lot bigger stuff.
perfect. Yeah. Got it, thank you.
And then the last manual review topic is secondary and ill-defined neoplasms. We discussed this in October. Staff had been instructed. We currently have one line below the funding line that
Page 156, thank you.
that contains a whole big variety of very generic cancer diagnoses. Due to the concern that we may not be covering some people with cancer, staff had been directed to go through and try to find placements on covered lines. We did that in October. About 2/3 of the diagnoses were moved to covered cancer lines with a organ system that seemed to be appropriate for that diagnosis. What was left on the line were extremely generic diagnoses, like malignant neoplasm of abdomen, which doesn't tell you what organ or what organ type. However, those might be used for people who don't want to pursue like, you know, really extreme therapy. They might use that, you know, if they see a big mass on imaging study and they want to go directly to hospice or something, they might be using, I'm not sure why you would use these diagnoses. It could also be that you, there can be the case where there is a mass that's so mutated that you cannot tell what the tissue origin is. They still can, in many cases, have some treatment that could prolong life or at least improve quality of life. And staff were directed to look at the remaining, 20 diagnoses remaining, and reprioritize so that these would be in the covered region. So that what's currently left on this line are very vague diagnoses. There was no way that I was able to kind of determine a appropriate covered line. And in general, there aren't really treatments, but there may be palliative care. There may be other things that might be happening. I doubt these would be frequently used. This line would be a code grouping that would again be covered in 2027. So the staff recommendation is effective January 1st, 2026 to reprioritize the line. And the reprioritization would keep, it's currently on category 9, which was inconsequential care. We would move it to category 6, which is fatal conditions, and then essentially leave everything else the same way. That would reprioritize it to approximately line 394, which is immediately lower than myeloid disorders.
Ariel, this is Chris. That's a lot of work. Thank you. Was there any kind of report that you could run to see how frequent those codes have been used or come up?
We did not run that. We could if you want to.
I'm curious about the economic impact because that's a lot of codes. If there's like something that falls out or stands out that would warrant another look.
What I could propose would be if you want to approve the staff recommendation, we could go back and do a data run. And if one of them is showing up frequently, we could take a deeper look at that particular diagnosis. Or we could just table this and bring it back with more data.
Chris, are you worried that they are previously not being approved or?
I doubt these are being overused. I
can't imagine there be, I get a chart note and somebody's got a Goomba that's cancerous. I'm not gonna deny it.
Yeah, and the only time that
And sometimes that's a clinical term.
in my extremely limited practice with this, I have only ever seen this code used maybe once, and it was for a patient who wanted to do hospice as a elderly person who didn't want any more diagnostic testing. And they had metastatic cancer with no primary, or no identified primary.
Yeah, so the risk, it sounds like the risk is low.
Very, very, yeah, I think the financial impact is very low.
I was thinking that a lot of these folks would actually move into coverage through palliative care or end up being covered by a different guideline.
Or they would get a definitive diagnosis that would be placed then on a funded line at some point.
Yeah.
When it could be, but they're often just used in the very beginning when things are unclear, or in this case, when they're not going to pursue further avenues.
Okay.
I think the risk of missing things and financial impact is pretty low.
Low. All right. Thank you.
Good question. Other thoughts on those three things? All right. Entertain a motion to approve staff recommendations as presented.
I'll make that motion.
Thank you, Lucy.
Second.
Okay, I think I got seconded by Brian there, sorry. All right, go ahead and run roll call, thank you.
Okay. Annette Awachi,
Aye.
Brian Duty,
Aye.
Mary Ann Grave,
Aye.
Max Kaiser,
Aye.
Lucy Langer,
Aye.
Sarah Love,
Aye.
Chris Pinzone,
Aye.
David Sagner,
Yes.
Holly Jo Hodges.
Yes.
It appears unanimous.
All right, you win a break. Let's take, can we do 15 minutes?
We can
Let's do
reconvene
15 minutes. All right, so at 9:55? Sure. All right, you're on break, go. Be free.
You vote against your own motion.
Yes, you can. Yeah. That's uncommon.
the background.
Hi all, we're gonna get started here in just a minute.
Okay, welcome back. Turn on your cameras when you're back with us, please. Thank you for everybody's attention today and perseverance. It's just gonna have to we have a lot of material to get through, so appreciate everybody. Yeah, so we are back. I think we've got most we have Lucy, Mary, Chris.
Chris, let me know she'll be a few minutes late coming back from break.
I see
Okay.
David, Brian, and Lucy.
Yep. All right. I think we're good then. We'll
Right.
go ahead and start back to our benefit update project.
Great. So we have a bunch of follow-up issues from our discussion in January. As you recall, one of the things we asked you to do was to pull out specific codes that you had any questions about.
And that starts on
and-
page 198. Thank you.
One of them was labyrinthitis. There was a question about not covering vestibular rehabilitation. I went back and looked at our benign positional paroxysmal vertigo review, and it did not find any evidence for vestibular rehabilitation for labyrinthitis. So the recommendation is continuing to be evaluation of medical management. Hypotension was called out. And it was noted that it should continue to be paired with the CPT codes for self-measured blood pressure for people who might need to be monitoring at home. And the staff recommendation is to move the self-monitoring blood pressure codes to the ancillary file and remove from all other code groups starting in 2027. That would match with the codes for the A codes for the blood pressure cuffs themselves that we approved in January 2025. Max, any concerns with that? Inhum, which is a very, very rare condition where the skin tightens around a toe and it can eventually cause amputation of the toe. The concern was that this might need surgery. Evidence review found no effective surgical interventions. This is a very extremely rare condition. I suppose this could be approved by exception if there was something that in an individual case could be helpful. There were multiple codes for various congenital heart problems, and you'll see that coming up in a topic that's very near and dear to my heart about congenital heart disease. There was a question about penile revascularization, and whether that would be needed for any non-erectile dysfunction indications. Staff could not find any. It's only used for erectile dysfunction, so the recommendation is continued placement on not medically necessary. And same with penile venous occlusive procedures. This is also only used for erectile dysfunction, so not medically necessary. Just as a note, erectile dysfunction is treatment of that is currently not in our plan, what we cover. And then there was a diagnosis for vascular disorders of the male genital organs. We were directed to see if that would be appropriate for use with any particular treatments. There are some subcodes when you look at coding references that include thrombosis of the penile vein, hemorrhage of the testes, hematoma of various parts of the testes, etc. So it seemed like this might be more appropriate on line 324, which is functional mechanical disorders of the genitourinary system. And then you already saw the clusterosis for the gallbladder, lesion of the sciatic nerve. There was concern that this might need to be paired with surgical release. And actually, looking back, we actually approved a change that was effective as a consent agenda item back in March 4, I believe. And then the neuralgia paresthetica you saw. So we do have a couple of these things we'll talk about in more detail in a minute, but the ones that have current recommendations, anyone have any concerns or want to discuss any of the staff recommendations? If not, I would suggest moving on to a couple of the other follow-up issues that have a little bit more discussion.
Should we approve those
Do you
first?
wanna
It's fairly
approve-
straightforward, and
Do you want to approve each individually or do it? We could do that if you want.
we'll approve what we discussed so far.
Sure.
So how about a motion to approve what we've discussed so far as recommended by staff?
It's Miriam Elizabeth. I'll second.
Okay, great, thank you. We'll roll call.
One moment. Antoinette Awaki,
Aye.
Brian Duty,
Aye.
Mary Ungrave,
Aye.
Max Kaiser,
Aye.
Lucy Langer,
Aye.
Sarah Love,
Aye.
Chris Pinzone,
She may have stepped away.
David Sagner,
Yes.
Holly Jo Hodges.
Yes, yes,
It appears to be unanimous with one absence or one person absent from the vote.
Thank you. Okay, we can move on to our next follow-up issue, which is hidden penis. This is a condition where the skin kind of surrounds the penis. You can't see the penis. In our January urology benefit update project review, there were some concerns expressed about continued coverage of this condition because it was felt to be a result of obesity and doesn't require treatment. And staff were directed to look into this further. On review, we realized the confusion came from the fact that the guideline as currently in effect would require a list of conditions to be the result of a prior procedure. We removed that based on our expert opinion, and so then the buried penis no longer had to be the result of a prior procedure, which was what we had actually intended with the current guideline. I discussed this with a pediatric surgeon, and he thought that they do see this after circumcision when the scar contracts and traps the penis. He calls it trapped penis, but they have to use buried penis as the diagnosis because there isn't something for trapped penis. So the staff recommendation is to modify the urologic surgery penile anomaly guideline, and it would continue to include coverage of buried penis only when it is the result of a prior penile procedure.
You said it didn't need to be?
So the current
I'm
guideline
confused.
lists all A through H have to be the result of a penile procedure, and the urologists were like, sometimes this happens just from disease or from what injury, but not a procedure. So we struck that. If you could just page down. So the red wording was the result of a prior penile procedure. That wording was struck from the guideline at the recommendation of the urologist.
Overall, but we want to keep it.
But we
for
want to
buried.
keep it for buried
Gotcha,
penis.
okay, okay, got it.
So buried penis from like obesity wouldn't be covered, but like
Right.
with the peds urologists were saying that they sometimes see this as a result of like a circumcision that had complications.
The only code.
Yeah, they would refer to it as trap penis, but they use the code for buried penis.
Maybe I see that, or they put us as complication diagnosis. Or,
So this would just say that
yeah. Okay.
it's the intent that we currently have. Any concerns about that? Do you want to do a couple of these before voting?
Yeah, I'm sorry, I thought we were done with that bunch, so let's do the bunch.
Okay.
I don't have a list in front of me.
So spinal procedures, we talked about this also in January. Several questions were raised, so what you.
That's page 205. Thank you.
We had actually, looking back through the minutes and notes, we actually never approved the document, the entire spinal procedures benefit update. We tabled it because of the concerns some groups had. Or some folks had raised about essentially osteoporotic compression fractures. And so going back to kind of close up that concern, I realized we need to actually vote on the whole document, and then I bolded the changes that I've made to address the concerns that were raised about compression fractures. So essentially, we'd make a new code grouping for osteoporotic compression fractures that would allow treatment with kyphoplasty and vertebroplasty only with an extremely limited guideline, because these procedures haven't been shown to be very effective. But the guideline you'll see in a minute, it's extremely limiting. So there would be a new code grouping called kyphoplasty and vertebroplasty. It would include only the age-related osteoporosis guidelines and contain the vertebroplasty and vertebral augmentation codes and a guideline. The guideline would say, page all the way down, to guideline note 109, vertebroplasty, kyphoplasty, and sacroplasty. They are not medically necessary for routine osteoporotic compression fractures. They would be covered if you were hospitalized due to pain with a well-documented acute fracture. You can't walk, and you can't control the pain with other procedures, and you have had 4 to 6 weeks of conservative management. And then sacroplasty would not be medically necessary. That's our current guideline, actually, from when we do cover it.
There was concern that kyphoplasty was more effective than vertebroplasty, right? We thought that.
They're both
Catherine thought that, and that was my impression as well.
minimally effective.
Right, none are great, but it sounds like when you even looked at the evidence, that was substantiated. Because wasn't she saying last time that one wasn't even, I get it confused, but I think the vertebroplasty wasn't even like performed anymore.
Right.
But you couldn't find any expert guidance or guidelines, right? That was my impression as well, I'm not orthopedic surgeon, so.
Yeah.
Okay.
I think our current guideline, none of these are, the evidence shows that they are effective for pain relief in the extreme short term, like a week or two.
Right.
But they have risks, including the glue embolization or the cement embolizing and causing problems, or actually worsening pain in the long term or other problems. So I think the current guideline wording, this is an uncovered line, but it's basically somebody who's in so much pain and nothing else has worked.
Yeah. If I remember, the discussion came up because of the difference that we thought between those two procedures. Okay.
Yeah, and I don't know if vertebroplasty is done much. Kyphoplasty is still
right. That was
a
our
lot.
Thought, so I was surprised that even guidelines didn't cover one. Okay.
Maybe because one of them is not used. So.
Usually at least updated. Yeah.
And then we have to approve the entire spinal procedures document. There weren't really any other concerns with the spinal procedures document when we discussed it in January. It just never was actually voted and approved.
So are we to a point where we have motion for all of the previously discussed issues?
No, we got cervicogenic headache and then congenital heart disease. Okay.
That's page 222.
Do you have any other concerns, Max?
Nope. No.
I think part of the concern may have come from originally the kyphoplasty and vertebroplasty was going to be lumped into conditions of the back and spine, and this actually pulls it out into its very own little mini code.
Yeah, I think we wanted to give similar guidelines to what we had before. Yeah.
If no questions or concerns about that, We also had cervicogenic headache follow-up. We talked about this also in January when we were talking about migraine and tension headaches. There was concern raised about adverse events. Cervicogenic headache was proposed to be paired with osteopathic chiropractic manipulation. And this would have to be of the cervical spine because of the cervical source of the cervicogenic headache. And there was concern about adverse events, and staff were tasked to find more information about that. So there have been several systematic reviews looking at adverse events after cervical spine manipulation. The most recent was published last year and had 14 RCTs. There were 187 adverse events during 31,000 person days. So there are adverse events, but they are extremely rare. There was a VA evidence-based synthesis published in 2017 that found a very, that the adverse events are common, but most of them are just sort of mild pain, etc. Of note, they didn't actually include any studies that really specifically talked about adverse events. They were just trying to kind of mine the adverse events from the studies they could find. And then older studies looking at adverse events. One study found multiple case reports of serious problems, but there was no denominator, no sort of basis to sort of see. And then this was, there was public comment from chiropractic folks who submitted additional literature, which was abstracted. And just for your situational awareness, we're gonna have some public testimony from the Chiropractic Association, et cetera, at HERC meeting. I believe most of what they are talking about is that this is a common thing done by chiropractors and osteopaths, and it has good evidence, and though there are adverse events, but a very low rate. So the conclusion that the HERC staff drew from the available literature is that this is an effective treatment for cervicogenic headaches in the short and medium term, but not the long term. There are adverse events reported, but the rate appears to be very low. Private payers are paying for this. And we continue to have the same, what you see in your documents is the same recommendation. I am going to propose, however, a friendly amendment to the staff recommendations. There was some concern among staff when we had an internal meeting about adding the CMT OMT to the conditions, to the headache line. And we actually felt that it might be more appropriate instead to add the cervicogenic headache diagnosis code to the back line, because it's a condition, a headache condition resulting from back problems. Then we wouldn't have to deal with code pairings and things with sort of inappropriate headache diagnoses. And then we would continue to have the same guideline. Actually, we actually wouldn't need the guideline. We could just delete the guideline. So the staff amendment would be to add, yes, would be basically to strike the current guideline, and instead we would add cervicogenic headache, this one single ICD-10 code G44.86 to the conditions of the back and spine line, or code grouping that already has manipulation codes, and then strike the guideline because it would be the only headache on that headache type in that grouping. We wouldn't need the guideline.
The ICD-10 that you're adding is this one.
Yes, that would be added to the conditions of the back and spine line, not the headache line. And we wouldn't need the guideline anymore. We could strike the guideline.
In conditions of the back and spine line, it's only medical.
It would be in the medical back and spine group, which does have manipulation, spinal manipulation.
Right, I'm just thinking of what other things are covered on that line. Would we accidentally add coverage for something else on that line?
Acupuncture,
massage,
massage,
PT,
PT.
OMT/chiropractic.
Yeah.
That's it, right?
Yeah, no surgeries or procedures on that line. like no interventional procedures.
Or if you would prefer to have it just pair with CMT-OT, we could continue with the staff recommendations that were in the document, which would put it in the tension headaches and then have a guideline saying that it's only in that code grouping.
Did we look at massage and acupuncture?
Yeah, do we have evidence that the others are beneficial?
We did not.
That would be a drawback.
Okay. If you would prefer the current staff recommendations, that would.
Sorry, what was the complication with the staff recommendation?
Oh, that CMT and OMT would pair with a whole variety of headaches, but we would have a guideline saying that it actually is only medically necessary for cervicogenic. You would just have to have that extra.
I mean, would it be cleaner to move cervicogenic to the back and spine, but also keep the guideline though? So that's gonna.
Actually, it would be bad.
That's worse, okay. Why is that
Because then it
worse?
would say that it's only covered for headache and not for like general back and spine pain.
Oh, right, yeah, yeah.
We have,
Well, no, you can say with this diagnosis, only these things are covered in the guideline.
you could say cervicogenic headache is only included on this line.
Yeah, for.
Would you like me to wordsmith that and bring it back? Yes, please.
Yeah, it's okay, that's right.
Yeah, because we'd have to, I assume you want medications covered as well and so forth, according to the.
I mean, they're covered already, right? Because
Yeah.
it's already on a funded line.
Well,
that's
no,
what I was asking about,
currently
is
it's on an
covered.
unfunded line for cervicogenic.
Oh. Yeah, that's what I was asking about, what other things. We wouldn't.
Or if you want to do the staff recommendation, it would pair on the migraine line. There's acupuncture on the migraine line, but it has
Botox.
Limited to
it's limited. There's
12.
Botox, but it's limited with a guideline.
Yeah.
And actually, acupuncture on the back line is limited with that same acupuncture guideline.
Acupuncture on the back line, guideline note.
Has a
56.
visit limit.
It's just a visit limit, yeah.
Right, it's
Yeah.
only limited to
And it's only for high risk.
30, yeah, right.
Wait, what is the cleanest? This is.
Now I'm backpedaling.
So I know there's a lot of.
I think the cleanest actually might be what the staff had initially recommended, which was put cervicogenic headache in with migraine and tension headaches, and then the current guideline would limit CMT and OMT in that grouping to just cervicogenic headache. And it would also pair with medications and office visits and whatever other things are there for the migraine. There's a Botox guideline that limits Botox to just migraines. There's an acupuncture guideline that limits it to just tension headaches, I believe, in that grouping. So we already have guidelines.
Acupuncture's just for migraines.
Was it migraine?
Tension headaches. Well,
No, we added tension headaches because there's good evidence for acupuncture. So actually, staff withdraw their friendly amendment, having realized that there's already a bunch of guidelines on that line.
So Ariel was right in the first place, I was wrong. So.
Yeah.
I guess the only.
Duly
concern is-
noted.
But that would make meds also cover that diagnosis, right?
It's gonna be covered anyway.
Of
Right.
which there's a little,
No, but there's a lot of inappropriate prescribing,
well,
which is what I.
But that's it.
But I think
That's-
that,
We're gonna have to deal with.
again, I'm gonna be PA'd for a lot of the things I'm thinking of anyways.
But yeah, so I
what
think the
page are we on
cleanest
again? I'm sorry.
way. The cleanest way was the original staff recommendation, which is put it in with tension headaches and migraines, and then only cervicogenic headaches would get manipulation, spinal manipulation, because they're the only ones that would really benefit.
again, what page are we on?
225.
Thank you.
And that clarifies for other types of headaches too, that was the intervention talking about, so it's actually better for that as well. Okay.
Yeah.
Yeah.
And we acknowledge there is a rate of harm, but it's very low.
Okay,
And then we have one
Are we all-
more. It's congenital heart disease. I'm lumping this in follow-up because there were a series of diagnoses of congenital heart problems that have no bearing really on health, like dextrocardia, where the heart's just rotated in a different direction, et cetera.
And that's on page 228.
There was concerns about not covering some, and those were kind of, we wouldn't really cover them for anything, they would just be in the evaluation and management grouping. And there were some concerns that there might be some appropriate, in tests or other appropriate things, that, and some of those, even though they're not necessarily a medical problem, if they're part of a constellation of things, they might actually need to be fixed while they're fixing whatever else. So then I went back to my, my biggest pet peeve, or one of them about the prioritized list, and that is that we have 19 lines for congenital heart disease, which are all covered. And it just seems overkill, like, these are all, and also babies don't necessarily follow textbooks, so they may actually have more than one, their actual anatomy may be a blend, and so it might be hard for, I want the cardiothoracic surgeon to do whatever they need to do to fix the baby part. And we currently have no guidelines and no restrictions on any of these lines. So the staff recommendation is to combine all 19 lines as well as the 6 codes that were like dextrocardia, which means the heart's rotated in a little bit of the wrong way, or situs inversus, where like the whole internal organ structure is rotated the wrong way. Put them all together in one code grouping called congenital heart disease with all of their current procedures. And then we let the surgeons sort it out.
So we're changing, we're keeping coverage for this, right? It's just simplification.
Yeah, so we're merging 19 lines down, and I think it would actually be an improvement because a particular patient's anatomy may cross between a couple of different syndromes, and so it would allow, you could pick and choose which procedures a particular patient might need that are currently separated out into 19 lines.
Sure. I mean, I would add, this isn't just babies, these are adults too. There are a lot of adults who have this.
Do you have concerns? Do you think there might be a problem by?
No, I just wanted to say it's just not babies who have congenital heart disease. But
I'm sorry, I didn't mean to imply that. Yes, many of these, if they're severe, are treated in infancy, but many of them, especially even those treated in infancy, may need additional things.
Oh, yeah, I'd say most of them actually are treated as adults of the ones on that list, but sure, I agree. That's fine.
It's Mary. I really appreciate, I know this has been a big issue in the past and really appreciate the work on this. And I feel like every now and then we get a peek into what Ariel's mind looks like. And this is a great example. And this looks great.
Thank you. And I don't think these are subject to overutilization. I mean, these are major, in most cases, major heart procedures that people are not going to overutilize. And then the 6 diagnoses that we currently don't cover, there really are just conditions that are just exist and don't really affect health, but this way they are involved for some reason in the whatever else is going on, they could be addressed. I don't think situs inversus can be fixed, but.
No, it doesn't.
No.
It's associated with things. It's a marker for other things, but it's not a thing itself. There are other ones that are considered benign congenital heart disease. There's several other ones, but yeah, that's fine. I agree.
Okay. All right, so now we'll take this as a bunch. So we already voted on what I thought was the first part of the simple stuff, and then whatever now is left in A.
So we would be voting on buried penis, spinal procedures, cervicogenic headache, and congenital heart disease, or congenital heart conditions.
Yes.
No lack of disease in there.
Okay. Okay.
A and B.
This is Chris. I was not present for the first one, but I heard the other 2, so I can vote on the latter 2, but I did abstain for the first. I don't know how that's gonna complicate Daphne's role taking.
Chris, I would just suggest you abstain from all. We don't need you
that
for a
works.
quorum, and that would be cleaner.
Okay, will do.
So I entertain a motion to approve those as discussed staff recommendations.
Motion to approve as presented.
Second that.
Thank you, Max and Lucy, and we'll roll call for votes.
8. Antoinette Awachi,
Aye.
Brian Duty,
Aye.
Marianne Grav,
Aye.
Max Kaiser,
Aye.
Lucy Langer is abstaining, yes?
No, eyeing.
So that was a yes for Lucy Langer. Sarah Love,
Aye.
Chris Pinzon.
I'm abstaining.
Okay, thank you. David Sagner,
Yes.
Holly Joe Hodges.
Yes.
All right. Motion passes.
Thank you. Okay,
Now we're moving
Now
on
we're
to something that
moving
might not be straightforward.
into eyeballs.
Yeah, so, this is the benefit update project ophthalmology review. In your packet, if any of you have any feedback on this, the way we've structured this, I'd love to hear it. As you've noticed, the benefit update project is coming to you in sometimes different formats, depending on kind of what we're dealing with. So the non-covered eye conditions were a smorgasbord of very different conditions. So at the beginning, I have an overview that just has the basic recommendations for all 6 of the subtopics. And then there are 6 separate individual reviews. So hopefully that was helpful to kind of orient you all. The first kind of the basis for our new ophthalmology coverage is going to be an ophthalmology office visit line. Ophthalmologists use different office visit codes than everybody else, like the 99213, 99214, that most physicians, surgeon, internists, specialists, they use those codes. Ophthalmologists have their own set of office visit codes that do include some kind of routine eye tests that they do with every visit. So there are a lot of eye conditions that are currently in the unfunded regionally prioritized list that need an ophthalmology office visit at most. And they might need medications, most of which would be inexpensive. So the new code grouping would have ophthalmology visits as well as medications, but there wouldn't be any surgeries or invasive things like injections into the eye. And then there were 2 procedures that are currently on unfunded lines that would be considered not medically necessary. So we had help from a variety of different, I'm sure you're all aware, ophthalmologists no longer do general ophthalmology, at least not in academic centers. So there was a wide range of folks who do all kinds of subtypes of ophthalmology. So their input was taken, and then you'll see individuals helped us with individual areas that was closer to their expertise. So the staff recommendation is to basically put in this new code grouping, conditions requiring ophthalmology office visits. The ICD-10 codes will be below, and then also moving in one covered line. There's only one line that only had ophthalmology office visits, and that was line 166, which is some infectious conditions of the eye. It would have standard office visits for the ophthalmology, but no procedures. And there would be a couple of guideline notes that would need, or one guideline note would need to be modified just with our usual, instead of on this line, it would be medically necessary or not medically necessary. And then we currently have an extensive guide, or not extensive, but we have a detailed guideline about lattice degeneration and asymptomatic retinal tears, et cetera, that basically say that it's only covered for visits and dilated eye exams. We wouldn't need that anymore because that's all it would be covered with. And in this group would include things that I know might raise like some concerns of medical directors, like acute conjunctivitis, but we actually heard from the pediatric ophthalmologist that this is not an uncommon thing that they see in their office that are referred from a primary care provider. Again, it would just have their specialty evaluation and eye drops. Also on this line would be routine. That condition would, also be available for just routine office, like a primary care, pediatrician, family physician office visit. And then there's a whole host of other things that they didn't see any problems with. And then moving, there was a couple codes that were on an uncovered and a covered line, and the suggestion would just be leave it on the covered line, except for orcocinilis, because there's no treatment for that condition, and it's currently on a line with some treatments. And then there's a couple of unspecified codes that would be added to the unspecified code grouping file.
Can you remind me what the specified code group does? I don't remember.
Oh, actually, they don't pay, and I think in another discussion that we had, I'm sorry, this actually was all put together for the January meeting, and I didn't really do a lot of redoing. I think we may have decided to cover all of those because we don't know what they are. But we could either leave them undefined, we could put them in evaluation of medical management, did put them in ophthalmology visits.
My instinct is to put them on uncovered because I see like unspecified or the various intervention codes used for things that don't have a diagnosis for a reason.
So unspecified would mean not covered.
Okay.
It's too non-specific.
Yeah, okay, good. Sorry, I couldn't remember.
And especially in the
unspecified code group get translated in just evaluation of medical management only.
Did it? I can't remember the discussion from January. I think it may have been, yeah, we said all the unspecified codes go into evaluation and management because, especially for like,
visits.
right.
For the diagnosis.
I would agree with that.
But if we do medical management, they don't get ophthalmology visits, so if you went to your family doctor and they gave you one of these unspecified codes, they would be paid anyway. And if they saw an ophthalmologist, they would get paid for the evaluation visit. But there's so many codes in ophthalmology, I can't imagine I would come up with that one.
Right, that's always my thought about unspecified.
So
they need to be more specific.
Especially a subspecialist, a specialist, that's kind of their point. Yeah, I get it, there's some things never fit perfectly.
yeah, so yeah, friendly amendment would be, to be consistent with what we decided for some other things in January, instead of unspecified code group, this would go into the evaluation of medical management code group in case a primary care doctor diagnosed it, because they don't have the expertise to come up with a better diagnosis.
But there is an unspecified code group and that's just a non-covered. Is that true?
I think the decision was that it was all gonna go into
Okay, so there is,
the
okay,
med management.
that doesn't exist, okay.
And part of it's because IC10 is so awful that a lot of primary care providers will just pick unspecified.
Yeah. They click whatever the EMR.
Yeah.
The first that sort of fits the description, yeah. Guilty.
Never.
I would, exactly, I would never.
So with the amendment to be consistent, unspecified would then translate right over into evaluation of medical management. So they wouldn't even be able to have a follow-up visit with the ophthalmologist.
They would not be able to, without a more specific diagnosis.
Right.
Okay, gotcha.
But even
Okay,
like,
good.
when I was challenging the ophthalmologist about like, does acute conjunctivitis need a follow-up visit? Like the ophthalmologist people, so you'd be shocked at how many times we're asked to see somebody again for that, so.
And they don't think it's necessary.
So if things go real bad, it is not necessary.
Yeah.
I'm not even sure the first visit's necessary. Okay.
Okay, that's what we're trying to,
Yeah.
we're trying to decipher from your body language. Okay, got it.
If you don't feel that acute conjunctivitis should be an ophthalmology office visit, if it goes into the evaluation of medical management, they would still get one visit, they just wouldn't get follow-up.
Totally fine,
Yeah.
well, different comfort levels. Sure. But yeah, sure.
Ophthalmology is okay.
Apparently it's a need. I don't want a bunch of members getting stuck with a bill for something that they essentially control. Which they wouldn't have to
Right.
sign a certain form, nobody knows exists, but.
Okay. So other than the friendly change, you're all good with this? Okay. And then the next one is corneal diseases, and the cornea specialist, Dr. Winston Chamberlain. It's not a great name, reminds me of like some like Prime Minister of England, probably because it is a couple of them, isn't it?
Yes, combines a couple.
And that's on page 241.
So I talked to him about corneal conditions. The cornea, if you all remember, is the sort of clear front of the eye. If a lot of these conditions will cause that to become abnormal and can lead to vision loss. So the staff proposal is to create a kind of a corneal conditions. So the ophthalmology group is a little bit different than some that you've seen so far, because a lot of these ones that we're going to go into now, I pulled covered and uncovered lines together to basically make a little bit more coherent grouping. So we looked at all of the lines that contained cornea diagnoses and kind of putting them together with the treatments. So that's a difference, but I think it'll actually improve things. It'll kind of, again, streamline things. So rather than saying like you've got like these different corneal conditions all in different places with different treatments, they're all just going to be lumped together because they all have about the same treatment. Repair of the facial nerve is proposed to add to this because abnormal innervation of the eyelid can cause corneal ulceration and other complications that can lead to blindness. The main thing we probably are going to need to talk about is medical contact lenses. According to Dr. Chamberlain, they use these as sort of corneal bandages. So they have this thing that goes over the eye to kind of cover it. But these are pretty much across the board not covered by private insurance. So I think that's something that we're going to need to touch on. Because of that concern, there's a guideline proposed that would limit it to conditions that are vision threatening. We'll see this in a minute. And then most of this is just sort of a combining of a bunch of lines together. So there would be a new code grouping disorders of cornea, which would have as the diagnoses and procedures that are in the long tables in this document. They would also have some facial nerve repair, grafts and suture codes. And then all of the CPT codes from line 307, which is the covered corneal line, would be in there, as well as their covered HCPCS codes. There would be two new guidelines that would be based on, well, actually one is a modification of our current guideline 9, and the other would be a modification of our current guideline 168, just formatting changes, and then a new guideline about medical contact lenses. The medical contact lenses would say that these are only covered for conditions that are vision threatening. And for another friendly amendment dated last week, it would be March, not January 2025 for all of those guidelines. So there's a variety of conditions, and these are on many different lines. Some of them are infectious, then they're on their infectious lines. Some of them are nutritional, and they're on nutrition lines. Bell's palsy, acquired disorders of eyelid retraction, keratitis, corneal opacities. Unspecified code groups would be turned back into office visits, as we've talked about before. Keratoconus, which currently we have covered, would be in this group. Sjogren's syndrome with keratoconjunctivitis. So these would all be sort of put in together. And then there would be all kinds of currently covered codes that involve procedures to things with the cornea. And then the last one in the last table, 92071, that CPT code, which is fitting for a contact lens for treatment of ocular surface disease. Currently it's only on uncovered lines. They're not covered by private payers at all. So we could debate whether we want to cover them, if we want to cover them with the guideline that I'm proposing.
Why aren't they covered? Is it because taping the eyelid shut is equivocal?
They're contact lenses. They're actually apparently pretty expensive.
But I mean, we
How is
pay
that
for
better
expensive
than-
things that are effective, but how is it better than just taping the eyelid shut? Because isn't that the treatment?
It's a treatment. Or actually they suture the eyelid shut. Rather than tape it.
There are things that last that long.
No, they just it's a suture that they just put
No, I
in
mean, the
and
things
then
I'm
take
familiar
it
with
out.
primary care doc are things that heal in a days.
These are more like, yeah, ulcers and I don't know.
What's the other, like a day? Okay, I don't either, that's why I'm asking.
But if you don't wanna cover these, I think that would be in line with private payers and then we would not adopt a guideline.
Wait, so why, besides expensive, because private payers pay for expensive things that are useful, is that what I'm talking about, why they don't pay for them, because you just close the item?
I mean, I can speak on this a little bit. So when I helped Ariel research this, so there's a lot of people that have chronic dry eye, and so a lot of people, some ophthalmologists would recommend this for chronic dry eye syndrome. And so that, you're talking about the medical contact lenses, yeah?
Yeah.
And so that's based on the high unit cost of $2,000 to $3,000 per pair, it maybe lasts a year or two. I think that's where the pairs are coming from and not covering them.
Do they, the circumstances of ophthalmologists, that is it's easier than meds and drops?
I think it's a lot of people have
meds and drops?
dry eye, a lot of people therefore have refractory dry eye to drops.
But that's not life threatening, like vision threatening, chronic dry eye is not.
If it's severe, it's possible.
Yeah, so I
tears.
think that the vision threatening can be a clinical judgment, and what one person thinks
That
is
was
vision
my
threatening may
question.
not be considered that by another clinician, so that I think also factors into private payers' decisions.
This is Mary. Oh, sorry, go ahead.
No, go.
I was gonna say, I'd be really worried about opening the floodgate on contact lenses. I mean, we've all approved them at times when a patient has some unusual condition and has failed standard therapeutic, but I would be really worried about suddenly overdiagnosis of dry eyes and there's standard treatments that are available, but that seems like it could be an incredible economic impact. But I'd be curious of others' thoughts on that.
And we could make them what we call not medically necessary, which would still allow exceptions.
I would favor that.
Okay.
Similar.
And then we would not need a guideline.
Ophthalmology notes are very different, and they're not always as direct as our guideline notes
They're
are written.
Greek.
Well, they also don't have a fair amount of guidelines that seem to differ with how they evaluate people clinically, so the things I'm looking for, they don't always chart. I'd be really concerned about saying something as vision threatening. I don't think they identify that frequently.
So does anyone want to argue for coverage? I'm hearing kind of a consensus against coverage, but allowing exceptions. Which is our current coverage probably. Any concerns with the other issues here, which is mainly kind of combining several lines together and kind of having all the cornea stuff in one spot?
This is Chris. I think it's a great idea actually, because it'll be this, I'm imagining what I've learned from volunteering with KCI is there's like 7 different specialties for each organ part of the eye. And so I think it's a good strategy because there'll probably be another one for retina, like maybe 3.
Yep, you're gonna see more.
Yeah, so I think it's a good strategy, and it sounds like it's also aligned with ophthalmology, and so you're gonna hopefully get buy-in from those specialists too to like use their time efficiently for those things that relate to their practice. So
The
I
specialists are
appreciate
highly
it.
in favor of this.
I beg your pardon?
This rate.
Yes, yes.
I'm sorry, I didn't hear those last few comments.
Oh, I'm sorry. Liz was just trying to confirm with me. What you see on the screen is that the CPT codes for medical contact lenses will be based on not medically necessary, and we will not have a guideline.
Yeah, I'm kind
just
of with
wanted to
Mary on
confirm.
that one.
Okay.
But in terms of your approach to the code groups, I like it. Thank
Okay.
you.
So everything else folks are comfortable with? Do you want to talk about brow ptosis?
Please.
So brow ptosis is where the eyelid sags. It's frequently a cosmetic condition, but it can result in loss of part of the visual field. And this, all private payers and Medicare have coverage policies. because it can be so variable from just a cosmetic procedure to a vision interfering condition. And Dr. Davin Ashraf, who's an oculoplastic ophthalmologist, provided all the input here. So the recommendation is to create a new code grouping called browtosis. It would include gender dysphoria as well as browtosis diagnosis codes, and then browtosis repair and the general ophthalmology and medical visit codes.
All right,
There would
folks,
be
I was a little late. That's on page 249.
And then we would use our current browtosis guideline with just the changes from instead of in line, on a line to medically necessary. The impact of this would be, we currently have a covered and a non-covered line, and all of it would become covered with this guideline. And then also medically necessary for gender affirming care. I apologize. So we have two covered lines that have for congenital and acquired browtosis that have all the criteria for when we cover it, and if they don't meet that criteria, we don't cover it. So this would basically just be converting it to our new format with our updated date of last review, which would be March, not January. And then it would just include the browtosis and gender affirming care, and then the browtosis guidelines. So essentially, it's actually our current coverage just brought over into a better form.
Did Dr. Ashraf look at our guidelines?
Yes, he thought it was very appropriate.
Okay. Because this is one of the ones where, because this is very close to the Medicare criteria that
Yes,
I get from ophthalmologists.
it is pretty much the Medicare criteria.
Yeah, but they don't often include some of this information.
Oh, he was saying that this isn't consistent with all the, like, what he does for everybody, and he liked it, because.
I wish I could have this chart on stuff. And I've spoken to some ophthalmologists who are like, we don't even evaluate them that way. So,
And then
okay, great.
you just have to quote that this was evaluated by an ophthalmologist who said
No,
this
I
is
know,
standard of care.
No, I'm glad, that's
Changed
why.
their practices, but
I wasn't sure if I had an uncommon experience with that would come, so I want to make sure.
Oh, it's common.
Okay,
common experience.
But he did look at it in detail, and
okay, good,
no suggested changes other than, just the wording modifications.
great. I was always thrown because I was like, Medicare, what? All Medicare patients, I know that people just write it, the guideline is, okay.
We wrote our guideline based on Medicare.
Right, it's like, it's basically.
And his response when I asked him to look at the guideline was like, this is the guideline, like, this is what we do, so.
Okay. Cool.
You can quote him, yes, as having reviewed it as an
Great.
expert. And
Great.
not suggesting.
Exactly, participating.
I mean, all of these things make sense to me, but like, I've had to teach myself what's like that kind of thing, because nobody writes that.
Because ophthalmology is Greek.
I
They
look-
actually probably write it, but it's like,
I look at their
it's
pictures.
sigma delta equal 2.58, and that
Right.
means it.
I had to look at pictures and go, well, usually it's a pseudomarginate, it's this, people look. I've had to go that deep, so, okay, great.
Any other concerns there? Otherwise, we can move on to lacrimal duct obstruction. The lacrimal duct is the tear duct. It's frequently blocked in babies and then will developmentally open. It can be blocked in older children and adults because of infection or injury or other issues.
That's
when the
page 251.
When the lacrimal duct is obstructed, your tears don't drain normally, so the eyes will frequently tear. The ophthalmologists that were consulted were concerned that if we don't treat lacrimal duct obstruction, it can lead to eye infections and other complications. They felt that we should cover it with a guideline similar to Medicare and private payers. We last reviewed this as part of our ICD-10 conversion in 2012. And at that point, there were some interesting quotes that I found in our minutes. I find no body in any literature search in any country that does not support the treatment of this disorder. Things like that. So they very much wanted it covered. Medicare does cover nasolacrimal punctal dilation, so kind of opening up the opening, as well as duct probing, where you put a little very thin metal in to sort of open up the duct. They cover that if it can be reasonably suspected to address the patient's symptoms, which is usually excessive tearing known as epiphora, or chronic dactylocystitis, which is in kind of chronic inflammation or infection of the tear gland itself. Or a mucocele of the lacrimal sac, which is a sort of a mucus collection. Or infections when you're looking at intraocular surgery. NICE actually has had a policy that this dacrocystorhinostomy is indicated for patients with lacrimal sac obstruction or nasolacrimal duct obstruction, if they have watery eyes or infection, which is the dacrocystitis. They also cover endoscopic procedures, etc. Our same oculoplastic surgeon was our expert for this. He recommended creating a new code group, lacrimal duct disorders, and then create a new guideline that actually is changed from our current guideline. Our current guideline only covers the procedure for children who are 12 months or older who failed conservative management, and for children under 12 months with multiple episodes of purulent infections. That's our current guideline. The recommendation would be to have probing of the duct be and/or dilation be medically necessary. If you failed conservative therapy, which is topical antibiotics, or there's a massage called the Krigler massage of the corner of the eye that can help open the duct. When one of the following is present, the excessive tearing, mucocele of the lacrimal sac, chronic dacrocystis, which is the chronic infection, lacrimal sac infection that must be relieved before intraocular surgery, multiple episodes of purulent infections in children younger than 12 months, or congenital duct obstruction that cannot be cured by probing in children over 1 year of age. So it's kind of our current criteria changed to the Medicare criteria.
The coverage for excessive tearing is common. Because it can be significant enough to affect vision, but it can also just be annoying. We usually don't cover things that are just annoying.
We could modify the proposed wording, epiphoria or excessive tearing due to obstruction when vision.
What are there any other complications? Again, I'm not an ophthalmologist, so.
Mainly it was the infection.
Which you have increased infection with increased tearing?
With the lacrimal duct obstruction, so that would be all the other criteria.
Right, no, the other ones make sense to me.
Yeah.
They are infection things, but the excessive tearing ones.
The excessive tearing is basically following Medicare, but we don't have to follow Medicare. We frequently don't. We could strike that one.
I feel like I need an ophthalmologist to confirm my impression of it. Because I'm not an ophthalmologist, that's why I'm here.
It's not just tearing though, you've added the acquired obstruction too, so there's a physical piece to it as well, right?
Right, there's a whole variability of what
But if the
excessive
obstruction
tearing
causing
is.
only tearing, is
Right.
that a problem? I guess is what you're asking.
It's annoying. We usually don't cover annoying things, we cover clinically significant impact things. Which it can be enough to affect vision. Because it's water in front of your eye, right? But I think there's also times where it's people just have excessive tearing.
And I'm happy to have him come in.
We can just ask him.
Okay, ask.
If it's obstructed though, wouldn't it increase your wouldn't it increase the pressure in the eye?
No, so this is the
Duct, it's just the
kind of in
duct.
the nose or this area, like between the eye and the nose. It's not in the orbit.
Okay.
Do we have other criteria for the surgery? Because if the probing doesn't work, you do the surgery. Do those?
Those have no current guidelines. We just, we don't, I think we actually don't cover the surgery. The surgery is currently on uncovered lines.
And the specialist didn't discuss covering the surgery?
He wanted them all covered.
Okay, so I mean, that's what you do.
Removal of foreign body,
The probing
incision,
doesn't work.
drainage.
You essentially make it like a new hole in the side of the nose, but drains into your nose instead.
Right, yeah, and there's a whole multiple treatments that aren't covered right now, that he wanted to have covered. And like I said, I'm happy to invite him if you want to come, and they've
I'm
all
sure he wants
gone.
them all covered.
Exactly.
I guess I just don't follow the logic of like we do half the workup, but then if the simple thing doesn't work, we actually don't fix the problem. It seems like approving a half measure that you either think there's significant problems that you approve the
So,
whole
do
treatment
we
pathway. or
wanna
you don't.
modify the guideline to say that you have to try like the probing first before you do surgery, or?
I mean, if we're gonna cover surgery, you should definitely do probing before surgery, right? Like, probing is not benign, it can be pretty aggressive, but
Okay, so
Yeah,
what I'm
definitely
hearing you
surgery
say
step.
is, we should talk to our expert about the chronic tearing criteria. Is there something that could be more specific or more, not just chronic
yeah,
tearing,
more
but is
for
there?
these other
more-
morbidities. that I'm
So
not
ask him
aware of
about that, and then, when should we cover, cause the guideline is just about probing, when should we add surgery to it, and what should be the criteria for that?
yet. It seems like if we agree that we should approve probing, it seems weird to stop halfway through the treatment pathway. And it does seem appropriate for these kind of infectious criteria to cover treatment.
Okay. So my proposal for you all, if you're okay with this, is table this specific part, and I will talk to our experts and try to get further information, and we can bring this back, and I'll invite him to come.
Okay.
But he won't, they were very interested in what we're doing, so
It is a very different specialty.
we wanna get it right. Okay, so the cornea stuff, I think we're good with, the office visit stuff we're good with, the brow tests we're good with. The lacrimal duct, we'll table, bring it back.
Yeah.
Let me save this. Yeah, I thought this one might be a little bit more controversial because it
There
can
is
be
a lot.
minor, it can be major.
Those types of things usually aren't covered in adults, but if there's recurrent infections, that kind of makes sense.
Okay.
That's why I had questions about the tears. Really, those things aren't covered in adults.
I think I have enough notes. I might get in touch with you if there's if he's kind of wondering like what your specific question is or something. The next ophthalmology one is eyelid disorders. And so the changes are, there would be a new line that would have funded and unfunded and put together with a new guideline that really mirrors Medicare and private payers. So
Page 256.
this particular topic includes a whole bunch of Greek words that I needed to actually find the definitions of, like blepharoptosis. So these are basically all conditions where the eyelid is either turned outward or scarred or doesn't completely close or otherwise it can be loose or redundant. So there's a problem with the eyelid either not closing correctly, closing too much, not opening correctly, you know, all those kinds of things. There are different sort of recommendations for when you would cover upper eyelid versus lower eyelid because of the difference in how they protect and move over the eye. And the expert that I worked with on this gave me a white paper from 2015 from the ophthalmologic plastic and reconstructive surgery people. They recommend upper eyelid surgery when you can't do daily tasks or vision related activities and or vision obstructing. And then they have margin to reflex distance and other very specific kind of criteria. And they have recommended documentation. Medicare has very specific criteria for this as well. And they have excruciating documentation requirements, et cetera. Private payers pay for these conditions, again, with pretty extensive guidelines. And Dr. Ashraf was also the expert on this. Poor guy has to deal with all the outside of the eye.
So this would be a new code grouping, disorders of the eyelid, and it would have a new guideline. We currently have a blepharoplasty guideline at 130. And there, I realize, and maybe I was channeling you when I wrote this, Max, there is some overutilization that might be expected, so, do we wanna even further limit coverage? And then entropion and ectropion, which are different ways the eyelid kind of twists out of place, would be covered based on Medicare and private payer guidelines. So our eyelid surgery, it's essentially an entirely new guideline. Blepharoplasty would be covered with 30 degrees of visual field loss. Upper eyelid contributes to difficult, if you have a prosthesis because you don't have an eyeball, if you can't tolerate the way the prosthesis is, or essential blepharoplasty or facial spasm. That's our current guideline. And then ectropion and entropion would be medically necessary, and then the criteria are kind of in depth from the Medicare guidelines. You have to have, and one of the symptoms that they include coverage for is excessive tearing, pain or discomfort, as well as ulcers or keratitis, which is a sort of an inflammatory process of the cornea. And then in entropion, you can get like eyelashes turning in and causing excessive problems. Eyelid, surgical correction of upper and lower eyelid retraction would be necessary when there's a functional impairment and you've failed medical management, but not for cosmetic purposes. And and then there's lower eyelid reconstructive blepharoplasty would only be covered when there's a metabolic or inflammatory disorder causing edema that causes visual impairment that you can't manage conservatively, corneal or conjunctival injury, or excessive tearing or irritation. Again, I understand that you have some concern about excessive tearing.
Same tearing question.
Same tearing question. And then there would be a whole bunch of things. And Bell's palsy would be kind of in this group, Horner syndrome, which is currently covered. And then all of these other specific codes. There are a couple things that were eyelid conditions that really don't need treatment that would just be on the ophthalmology office visit line. But mostly they would be in this disorders of the eyelid. And I'm anticipating that I'm gonna be asked to talk to Asher about the tearing and maybe have him come and address us.
Yeah, I think it's the same tearing question, right? Not all of those.
Do you have any other concerns or anything else that you want me to talk to him about?
Were these, I don't think I've seen these ones, were these taken from Medicare? Okay. No, it's just written, I read it in a way that I don't think it is meant to be. I was reading it as the photographs have to also show all these symptoms.
Oh.
It makes zero sense. It's you have to have photographs and these symptoms, but how it's written is.
Did it? Okay.
No, I think that's how it's written in my brain, it just doesn't separate those two clauses. It's probably a new thing, because it makes no sense that photographs show things. Because it
Actually, it is written a little funny. Like I'm looking at entropion here. Clear, high quality clinical photographs must document the lid turning inward, and you have to have.
I think that semicolon in the "and" means to separate it, but right, it makes it seem like somehow photographs are supposed to show subjective pain, discomfort, which isn't possible. Right, that's how I read them initially, and now rereading them.
I understand
going,
your
okay.
confusion. Yeah.
But if we took the Medicare and that's it, we have to spend words to make things.
But
Nobody's giving that feedback. That's,
I can. And it may be that I kind of took Medicare structure and changed
Oh,
it enough that
tried
it
to
made it a
make it-
little bit
yeah.
more confusing. Sorry to write myself some notes, since we're gonna table this one as well, it sounds like, I will look at wordsmithing it, I'll talk to Ashraf again. And I'll, since there's been a couple things that you've brought, that you've had questions about, I'm gonna ask him if he can come.
Okay.
Our May meeting is all people coming, so we might as well invite him then, or he'll come in August, or October, or whatever.
I'm assuming medical treatment for eyelid retraction is just dry eye stuff. This is gonna fail medical management.
They actually put in like weights and things like that.
That's considered medical, okay.
Oh, and then there was a facial nerve grafts case, you
Yeah,
know,
that makes sense.
yeah,
Yeah.
um,
Makes a lot of sense.
release of extensive scar tissue. Temporary closure of eyelids by suture.
Hey, there it is.
Correction of eyelid retraction. Okay, so I have on my to-do list the tiering question and just re-looking at the guideline and the way it's worded and trying to clarify that a little bit.
Sure.
And if you come up with any other questions before we have him come back, I'm happy to lump them all together.
Ariel, this is Chris.
Yeah.
I was scrolling on the table. It's helpful to see where you're going with the recommended code groups. And I was just wondering for these, are you also looking at the unspecified code group getting the evaluation medical management for these? And then in the CPT codes, there's one that doesn't have a 21280 didn't have a recommended code group.
Oh my God.
Technical stuff.
Okay, thanks for pointing that out. I don't know if any of these ended up with unspecified code groups, but there probably is somewhere. Oh, yeah. I see the one, 21280 doesn't have a specification, so I just made a note to do something with that.
Yeah, and HO 2.70 has the unspecified code group versus the evaluation medical management.
HO 2.70 is not.
In the ICD-10, the upper.
In the
table.
eyelid disorder?
Yeah.
Oh, I see it, yes, okay. Got that, thank you.
And
We'll fix that.
G51.9 also. It's the fourth line. 1, 2, yeah.
Okay, I see it, yeah, thank you.
Uh-huh.
Yep, good catch.
There's talk about Lazions, if I pronounce that right, and Ordeals, right? Where was that? 'Cause weren't we? Because they're on the code group.
Yeah, Calazion's in here,
Yeah, it's right next to the other, but they're
but that would be ophthalmology office visit only.
put on,
Is it not consistent between a couple?
yeah, because
They're-
excision of the Calazion was added to
Ah.
disorders of the eyelid.
Oh, okay,
So then I was
So-
confused about how all those align.
okay, that's a good point.
Because wasn't there discussion
excision-
somewhere that we did want to add it if they were refractory to disturbance
Well,
management?
conservative,
Or was that recommended? There was talk about it somewhere in here. And then I got confused about the code groups. Or am I making up the discussion?
No, so Calazion, we didn't talk about, that was actually,
Yeah. I
the
think I read it
Calazion was just
somewhere.
the optho visits, which doesn't have any procedures, so yeah, do we? I just made a note to look at that, see if we can make that, if it needs to be not medically necessary, if we're not gonna cover chalazion for other than, or do you think we should cover it in some instances? Should it be?
I mean, we do every once in a while by exception if they're refractory and causing basically issues with vision. And we do, but I mean, it's rare, but.
So
I've done a
treatment by
couple of
exception, and then we can put it in just the ophthalmology visit group, or do you want to leave it in this group and move chalazion into this group?
I'm okay with exceptions for how uncommon they are, but if other people see them more often, I wouldn't have a problem.
And Asha probably only sees them when they're really bad and need surgery.
I'd be surprised if he sees them at all. I think just general office,
Okay.
because it's an incision on the eyelid in the office.
Yeah.
Yeah, they don't.
Okay.
I don't think it goes to subspecialists.
Okay, okay.
But if any one of us reviewers see more of that, I'm happy to change that, but I don't see it that often.
And again, if you're like can't sleep tonight and you're reading all these codes and you have questions, please send staff an email and say, I'm also wondering about this other thing. Right now, what I'm seeing is that we can approve for ophthalmology, the general ophthalmology office visit, corneal diseases, brow ptosis, and then eyelid conditions and lacrimal duct disorders are tabled and will be brought back. Any other further discussion before we?
That makes sense to everybody? We all understand, okay, see everybody nodding their heads, good.
So moved.
I'll second, it's Mary.
Okay, Mary seconded, Max moved that to accept the discussion as presented
As modified.
and as modified. Okay, and it was seconded and we'll now vote.
All right, roll call. Antoinette, watch. Ryan,
Yeah.
Ryan Duty,
Aye.
Mary Ungrave,
Aye.
Max Kaiser,
Aye.
Lucy Langer,
Aye.
Sarah Love,
Aye.
Chris Pinzone,
Aye.
David Sagner,
Yes.
Holly Joe Hodges.
Yes.
Motion passes.
Okay, so we have a slight glitch administratively here. So we're gonna go ahead on to colorectal surgery, but it missed making the public packet, which means it's not in our packet either.
Yeah, so we're good, we can discuss the issues at a high level, but we'll have to delay the vote until next meeting, so apologies for that, we had some.
Which part was, because we have multiple parts, we can go through some of it, and if it was in there.
Well, so the entire topic of issue 2520 aerial about colorectal surgery, there were 3 issue summaries and they just got amended from the packet and I can't really figure out why.
Okay, well, we can talk about anal fissures. That was a
Well,
different issue.
that was there, we can, yeah, why don't we talk about anal fissures first, and then if we have time, which it seems like we will, we can talk about colorectal surgery as well.
So what-
at a high level.
So what we'll do is go through what we all have first, and then we'll have them put it up on the screen and we'll work through it. And then if there's any questions, they can come back next time and then we'll approve that next time. So we'll only be approving what we have in front of us.
Yeah, and anal fissures actually it was separated out because it has some current changes as well as future changes. And then, yeah, so you can approve or not approve or modify or whatever we can vote on this topic.
Yes.
And then we can just not vote and review the other colorectal topics or any.
Yeah, but I think if we'll have time to do it and then come back to it. So page 271 in the packet.
Thanks, Dr. Hodges.
You're welcome.
So anal fissures are small tears or gaps in the opening, where the rectum opens up to the skin. They're acute fissures in particular are very common. They can happen after a hard bowel movement or after diarrhea. Most of the time, acute anal fissures will heal after a few days. However, they can become chronic, particularly if there's an underlying medical problem, and there would be sort of a a tear in the anal opening that's present for more than 6 weeks. At that point, usually surgery is recommended. And we currently have sort of limited coverage, and I was asked to look at this. And the staff proposal was, we only got one public comment about this, and this was our PNT colleagues had reviewed botulinum toxin, and I excerpted the part of their review that dealt with the chronic anal fissures, because that's one of the therapies that they do for chronic anal fissures. So currently, acute anal fissures are not covered. They're on line 559. And chronic anal fissures and anal fissures unspecified are also not covered, but they're a little bit higher on line 519. Dilation of the anal sphincter is on a couple of covered lines and these non-covered lines, as well as a whole bunch of other sphincterotomies and fissurectomies and all of these things. They're covered for some conditions, but they're not covered for acute or chronic anal fissure. We have a guideline about chronic anal fissure right now that would allow surgery if you've had 6 to 8 weeks of conservative therapy and it's either progressing, you have pectinosis, or they previously healed but recurred 3 or more times. And then as part of our Botox or chemodenervation guideline, we have chemodenervation with botulinum toxin is included for treatment of chronic anal fissures, but again, that's a non-funded line. The PNT 2025 evidence review for botulinum toxin for chronic anal fissures, they found a not statistically significant rate of incomplete healing with topical nitrates, which is a medication that you can do. They did find evidence that lateral internal sphincterotomy, topical vasodilators, and botulinum toxins are first-line treatment for chronic anal fissures, depending on patient factors with moderate to high-quality evidence. Insufficient evidence for or against combinations of Botox and topical vasodilators, and then there's no evidence on specific dose. So essentially, there's good evidence that Botox and surgeries can work. Although some of the topical medications have much less evidence behind them. I was only able to find one private payer policy, and that was Aetna. They do cover Botox for anal fissures if you haven't responded to first-line therapy of these topical nitrates or topical calcium channel blockers. Dr. Dan Herzig, who is one of the OHSU's colorectal surgeries, and Dr. Rodrigo Pendraza, those are the two surgeons that we worked with, for example, our hemorrhoid guideline coverage changes. I reached out to them again, and they were very helpful in helping in giving advice on this. So essentially, acute anal fissure is normally highly effectively treated with just conservative management, which is fiber, increased water, topical medication, sitz baths. These are all currently covered. These are low cost, low risk medications or just lifestyle things. So they're currently covered even though the condition is technically non-covered. So the staff recommendation is to move acute anal fissure to say that they're covered, but they for these conservative treatments, but not for surgical or Botox. Those only should be covered for chronic anal fissures. Dr. Herzig and Dr. Pendraza recommended that the conservative treatments be tried for 8 weeks before anything more invasive would be expected to be tried. Chronic anal fissure is effectively treated with a wide variety of surgical techniques and the Botox, the chemodenervation. Treatment is recommended by expert groups. It's covered by the insurers that I can find policies for. Chronic anal fissures can be painful, they can be debilitating, and the staff recommendation is to move acute and chronic anal fissures into the anal fistula line, which is line 391, which is above the funding line. And of note, these were combined until 2014, when anal fissures were taken out and made non-funded. And then, so we would move the ICD-10 codes up to line 391 that we've renamed anal fistula and anal fissures. We would add Botox to that guideline, to that line, add a couple guidelines to that. And so the first guideline would be chronic anal fissures, surgery would be covered. If a condition persists or progresses in spite of 8 weeks of continuous conservative treatment defined as lifestyle changes, increased fiber intake, increased fluid intake, bulking agents, stool softeners, and topical medications, or the presence of pectinosis or fissures that have previously healed but recurred 3 or more times. The chemodenervation guideline would say for line 391, anal fistula and anal fissure, chemodenervation is included on that line for treatment of anal fissures that progress or persist after 8 weeks of conservative treatment with the same definition of conservative treatment. And then the chronic anal fissure entry would be struck. And then we would delete, first for October 1st, 2025, we would delete lines 519 and 559. And then for 1126, I'm sorry, we'd strike through them. 1126, we would delete those lines. And then in 1127, we would have that code grouping with the anal fissures, or anal fistula and anal fissures would become a code grouping with all of the same diagnosis codes and procedure codes, the same guideline, but it would be changed to say medically necessary instead of included on the line. So that's just the
covered.
I mean, they're like, what's the topical name?
Topical betadine.
Yeah.
It's compounded though.
Right, that's why I'm asking, because I'm not sure we have consistent access to the topical medications.
Do these others, they're Proxgel and other stuff.
Yeah, Proxgel.
Steroids and topical like
I mean, maybe it's
steroid
just
combos.
the matrix and calcium.
Yeah, the topical is about it.
Yeah.
The calcium channel blockers are, the betadine is the compounded only.
The surgeon,
But there's others.
the surgeons didn't seem, they didn't bring that up as a problem, that,
Right, well,
but of course they're doing surgery, so they're.
again, why I'm asking, and I thought I had asked him to nobody and have notes about it, but I don't think. Can't remember, I don't think we had coverage for it. I'd have to double check. I'm unsure about access to the benefit in the guideline note.
You wanna strike the mention of the island, just have,
They should be there, that's the appropriate sequence, but if we're putting that somebody has to do something, but we actually don't cover it on the pharmacy side, that's the problem.
So why don't we cover it?
Well, one's compound, but there's one.
Yeah, the topical nitroglycerin, which I'm not sure if it's the strength. I don't know if that one's compounded. The topical nifedipine is only compounded.
Right, that's
So I try to get it for a patient and
I remember there's issues with
different state
access.
and it was not.
I thought we talked about it before, I would have already asked the question.
Should we email our PhD colleagues about it then?
Well, I don't know if that would affect the CCOs, right? I guess if they if service covers it, then CCOs would need to.
Well, it's a matter of access. It's not whether we cover it or not. It's just
yeah.
the fact that it's
Yeah.
compounded
Okay.
and
It's
whether or
both.
not we cover compounded pharmacies. And then again, is it even available to access
In certain parts of the state.
in any part of the state?
I think
Yeah,
coverage and access are two different and both relevant questions.
Right.
Yeah.
Because there's also issues with whether or not we can cover things that come out of a compounded pharmacy,
Okay.
right? Max?
I think
I
there
remember
would be
there's
a
problem
problem.
accessing these treatments.
Why don't we
I can't
take
remember
that
the
back?
exact
Yeah, so the
issue, but-
question is, can we cover compound things that come out of a compounded pharmacy? That's been an issue in the past. And what is the true availability in general of these topical?
See if I can know about it.
Does look like the 0.2 or 0.4% nitroglycerin ointment is commercially available. It's not compounded.
Okay, great. From
Yeah.
from a write a prescription, take it to a
Yeah,
pharmacy.
Yeah,
that's what it looks like.
That's what we're looking for here.
And we
Yeah.
can talk to PMT and see what meds they know that we cover.
Maybe it's just one of them that access is hard, I remember.
But if there's easy access to one, we could just say in the guideline that, you know.
Yeah.
Right.
It's a poor example right now, or
Right.
such as, but we could just say whatever one is easiest.
Yeah, people can also choose to get the compounded drug, pay for the compounded drug, and if that's the option that feels right for them.
We've just learned if we put, for example, people here who need to do these things. Throw the pan if we put, for example, all those specialties, and they kept asking us to add more specialties.
Well,
These are
there's
examples.
other issues there.
For this exact wording is what I'm, yeah.
For example, just means.
So what I'm hearing is generally you all agree that the intended changes are appropriate, you just want clarification on medications, and we can,
Make sure
so
that's
we could talk to our PNT colleagues and then just bring this back and it'll have just a quick discussion at a future meeting. And I can also possibly talk to our colorectal surgeons and see if what they do. Maybe they compound it in the office, I don't know. Spit into something,
yes.
crush it up. Okay, all right, so this one is tabled for PNT input. And then, do we wanna go through the other colorectal issues just briefly?
Yes, well, what else do we have, is there?
There's sports and orthopedics, and then there's podiatry that we also have covered.
Yes, what I meant, is there some chronic anal fissures, was there something else after, was there?
The gynecology, sorry, that's for her clothing.
Yeah, we have ortho sports that we can go through in detail.
Of those sports, yeah.
Yeah, definitely.
And that's on page 308.
I just thought there was another colorectal, which I think still have.
Anal fissures table.
There's anal fissures and there's incontinence. That was
No.
also missing.
No, but this
Fecal incontinence and general colorectal surgery, if you want, we could go through that without voting or making a decision if you wanna just look at it.
I would, because it will make it faster next time, and if we have questions, then you can take them back and you'll come back with the
Perfect,
answers,
yeah,
so let's
I
go
mean,
ahead
I
and
may
you,
be talking to the surgeons.
yeah, so
Yeah.
if you can,
You wanna do that for sports?
yeah, I would, let's finish.
Yeah.
Sorry, my brain does best if we stay.
One body system at a
Right,
time.
exactly,
Okay.
thank you.
Why are they not letting me open? Do you have it open?
I have it, I access a totally different folder, so I'm not.
I think I have
Jason,
it
you might
open, but
be-
it's saying that I
I'm-
don't.
I'm closing, sorry. Just trying to troubleshoot why it's not in the packet.
Thank you.
Trying to help.
So there were 3 non-covered colorectal lines, but we've been chipping away at them. So we have completely revised our hemorrhoid coverage, so that is done. Anal fissures is another topic that we have just discussed. We have fecal incontinence, and then which is a topic we'll be discussing in a second, and then there's just a few leftover items. Essentially, what do we need to do? Actually, what's only left over is making hemorrhoids, which you've all approved at the end in 2024, into a code grouping, and so it's very straightforward. It's basically just taking all of the codes that are in the hemorrhoid code grouping and putting them there, and then making the guideline look like a guideline. Instead of included on the lines, it will be, medically necessary, not medically necessary. So essentially, this is taking our hemorrhoid decision that you already made. Actually, even if it wasn't in the packet, it's essentially just administrative changes to the hemorrhoid line or do we want to just bring it back
Just
as
to
a
be
consent?
safe, let's bring it back as a consent item. If there's
So
one
yeah,
that is-
this is, yeah, so essentially there were 3 colorectal topics: hemorrhoids,
anal fissures and fecal incontinence that were not funded. We've taken care of hemorrhoids, but we have to tweak it for 2027. And unless anyone objects to how we've tweaked it, I'll bring that back as a consent agenda item for the UP at our next meeting. The anal fissures we've just discussed, and that's coming back after we get some PNT input. And then the final topic is fecal incontinence. What? This is not. Okay. This, you're right, Jason. Something's really funny because we still have like all of like the DOJ disclaimer and a whole bunch of stuff in this.
Oh, I think there's a different version. I'm sorry, Ariel. Pull it back out. I think Liz has got the right version.
No, she's got the DOJ disclaimer.
Sorry, which one was?
Fecal incontinence.
Interesting. So we have this really long paragraph that
requires a DOJ disclaimer?
Oh,
regarding
everything.
fecal
And anything that is not brought
incontinence?
before the HERC has to have this disclaimer
Oh, I
in
see.
huge bold black writing.
I thought it was related to the topic.
No. So this just means it's a draft, essentially, to us.
But we take it off before we bring it
Right.
to you, which is why it's being flagged as weird.
Right, yeah.
Some are non.
Okay, so
I look at that
somehow
one.
or other, this didn't get the
I found
final
it, Ariel,
review.
it's in the folder there. If you click into the folder.
Okay.
And Liz, I'm about to put it in the meeting edits folder, and it's gonna have a very long name, so it's archive.
Is it the 1/6/25?
The one that says archive at the end. Modified 2/6/20.
Oh, okay. Open and read only. I'll save it as something else. That one still has the DOJ,
Okay,
so something really happened.
okay, we're gonna have to sort that out and bring it back.
But we can talk about the general gist of what the recommendation is. Yeah, so you guys have probably never seen the DOJ disclaimer unless you get something from me with questions. I, like the medical director, sometimes see this because it's anything that goes out to anybody outside of the agency for input. It basically just says this is not a final recommendation. You can't count on this. You can't use this for decisions, blah, blah, blah. Okay, so fecal incontinence is when you pass stool and you don't have any control of passing stool. It's pretty common, especially as people age. It can happen from physical injuries such as childbirth. Usually it resolves if you increase your fiber. For some people, they might need antidiarrheal medications, especially in certain neurologic conditions. You can wear like absorbable pads. But for people where the incontinence gets to the point where it becomes more of an issue and just wearing pads or using medications or whatever is no longer helping, you can do surgery. There's anal sphincteroplasty or tightening up the anal sphincter, sacral nerve stimulators, which stimulate the nerves to have a better tone, more tightness. And then a diverting colostomy is kind of a last ditch treatment, and it's usually done in cases where somebody has like a decubitus ulcer or other complication, and like we can't keep stool out and it's causing infection or worsening of that ulcer or something. They might do a diverting colostomy to help in that situation. We haven't reviewed this since 2013. And it's currently, fecal incontinence is on our dysfunction lines as well as on one unfunded line. I didn't find any evidence about sphincteroplasty or sort of recreation of the sphincter, any evidence about that. So that's not recommended. Sacral nerve stimulation, we have a guideline and we've reviewed it in the past, and the guideline is mainly for exceptions. Looking at just kind of updating our evidence review, there was a systematic review done last year, 36 studies, 3,770 patients, although all studies had a serious risk of bias. And it was not consistent what quote unquote success meant. They did use the fecal incontinence quality of life scale, and the studies that did use that scale found improvement in one or more domains with treatment. And with the sacral nerve implant, the later revision was pretty high, about a third of patients needed it revised, and about 20% had it explanted or removed. And in colostomy, there was no relevant evidence. Again, that's sort of a last ditch, not preferred option, so it's only done when folks really need it. There's an expert guideline from the American Society of Colorectal Surgeons, published in 2023. Anal sphincteroplasty may be considered in patients with a defect in the external anal fissure, but clinical results will often deteriorate over time. Sacral neuromodulation, which is a sacral nerve stimulator, can be considered first-line surgical option for incontinence patients with or without sphincter defects. Colostomy is an option for patients who have failed or do not wish to pursue other therapies. And then the Gastroenterology Society, they recommend sphincteroplasty for patients in whom anal injury is recognized shortly after, such as after a vaginal delivery, and symptoms persist despite adequate therapy of coexisting bowel disturbances. Sacral nerve stimulation is recommended for patients with fecal incontinence whose symptoms are refractory to medical therapy. And then creation of a ileostomy or colostomy is considered a last resort. Medicare covers nerve stimulators with certain criteria, as does, and Aetna covers anal sphincter repair, sacral nerve stimulators, and colostomy. Pretty much everybody covers colostomy again because it's like an end stage thing. Most cover sacral nerve stimulators with certain criteria. Sphincteroplasty, the coverage is very variable. So in summary, colostomy is a last line therapy, and this is done when there's an infection, an ulcer, other complication, and there's essentially like, so a sacral ulcer is an ulcer on the between the buttocks area, and if you don't keep stool out of there, it can become infected, it can become a lot worse, it can result in really serious complications. This procedure is not going to be overutilized. It's not a procedure people want, and we actually already pair these procedure codes on line 71, and we feel that guidelines restrictions should just be deleted. If a colostomy is sort of the needed therapy, that is probably for a good reason. Sphincteroplasty has not been recommended by experts in past review. New evidence review found very limited evidence of effectiveness. It is paid by private payers. And staff is recommending adding that sphincteroplasty to the not medically necessary code grouping. And in sacral nerve stimulation does have evidence of effectiveness based on previous and updated evidence reviews. And we felt that it should be added to line 71 to parent fecal incontinence with only technical modifications to the current guideline. The fecal incontinence guideline would say that you can have supportive treatment like diapers and gloves and surgical treatment, colostomy related procedures when medically appropriate. Sphincteroplasty is not medically necessary for treatment of fecal incontinence, and then the sacral nerve stimulation would have our current criteria with just technical wording changes. So essentially, we'd actually be adding the sacral nerve stimulators because it's only on the uncovered line right now.
And this is affected to 125.
Yes. And we're not voting on this, so just let me know if you have any concerns or want any additional working on it.
Everybody good?
Ariel, when this does come in front of us, will it be moved into code grouping again, or are we still sticking with the guideline note?
It's still gonna be, we're
Or am I-
adding these changes now to the prioritized list.
No, this is all code grouping, but I can.
Oh, I'm sorry, I thought
I
this
can
was the
bring it-
changes for October 1,
Um,
because we're changing the guideline now.
that was for 2027. because we currently don't cover the sacral nerve stimulators, but if you want to cover, a colostomy currently actually pairs without a guideline. So this would actually just clarify that we do cover it.
Okay. All right. So that's helpful, that the one's affected. I assume when we're modifying guideline notes, that always means they're going to be at the next update. So that's great, just make sure that the clarification there, that'll be helpful.
Yeah, all the BUP changes, unless otherwise noted, are for 2027.
Okay.
And
Remind.
so currently sphincteroplasty is only paired in an unfunded line, and we're just making it clear here that we don't cover it.
Got it.
And then the only other, like I said, colostomy is already paired, probably because of the need for it and, you know, unfortunately in certain circumstances. So we're just clarifying that we do cover it. And then, so the sacral nerve stimulator covered. Okay, so what I will do is these two documents will come back and they will be in the packet and we will consider them to be sort of consent items. I didn't hear a lot of concerns about either of those two documents, so we'll just put them in a consent, and unless somebody has thought about it or had someone else in their organization look at it and has raised any concerns, we will.
Well, they'll go out for public comment, so if we get some comment, it might.
Yeah, and then I will work with PNT on the Fisher question, and that also probably will be, I'll put it in consent, we can discuss it briefly, unless there's a lot of concerns and a lot of issues. If they're like, oh no, we cover like 6 different things, then I'll just bring it back as consent. If they're like, oh, right, we don't cover any of this and we need to work with them on it, it may be more discussion. Lots of nodding, people happy with that? All right. I apologize for the confusion with that. Yep, so we can move on to sports and orthopedics. So currently there are many, many conditions in the unfunded area of the prioritized list that are sort of minor sprains and strains or minor joint problems, et cetera.
That's page 308.
So this is a smorgasbord of all kinds of conditions. I had the pleasure of talking to an orthopedic surgeon, Dr. Eric Bosworth, as well as a couple of the OHSU sports medicine folks, Ryan Norton and Melissa Novak. So we got both the surgical and the medical side inputs for this. They recommended adding a physical and occupational therapy for a variety of conditions. They also recommended adding injections, joint injections for certain conditions. Most of the currently non-covered conditions will end up being in the evaluation of medical management code grouping, so kind of no change in coverage. Certain non-covered procedures will become not medically necessary, and then the guideline notes just need formatting changes. So there are a whole bunch of lines, peripheral nerve disorders, ethanopathies, chondromalacia, benign conditions of the joints and bones, synovitis, sprains and strains that are minor, etc. And what we would do for this topic is, as I mentioned, many of these would go into that kind of generic evaluation of medical management. And then we would have 2 new groups. One would be conditions benefiting from PT-OT. And there would be a whole bunch of new, all the PT-OT codes would be in there. And the ICD-10 codes that we would go through in the table would be in those. And then there would be an additional code group, conditions benefiting from PT-OT and joint injections. Even if you don't approve this, we could even tweak this and just say joint injections, and then everything in the joint injection PT group would be in the PT group, and then a few would be in the joint injections. You could do it that way if you want to. And then the guideline would be modified to, we have a PT guideline that would just be modified. The trochanteric bursitis. Currently we have a guideline saying it pairs with physical therapy and steroid joint injections. It doesn't pair surgical interventions. you wouldn't need that guideline because it wouldn't pair with surgical interventions, it would just pair with PTOT and joint injections. And then pectus excavatum would just change from included on line to medically necessary. And then there was one ICD-10 code that we had said that we only covered it for Form syndrome. We wouldn't need that really anymore. If you wanted surgery or whatever for it, it would be more, but it's a super rare condition and that might be better treated than it as an exception unless you want to keep wording in there. The management of acroclavicular joint sprain, so that's the joint kind of right here in the shoulder, which can be dislocated or sprained. We only cover currently for grades 4 to 6 sprains. And then surgical management is covered only after trial of conservative therapy. They wanted us to basically just make it clearer. Surgical treatment's only covered for 4 to 6 after conservative therapy. So they just didn't like how we wrote our note. They just wanted it made into a sentence with fewer clauses, basically. And then our significant injuries to ligaments, tendons, and menisci would just be sort of the typical modification. And then we have a smoking and spinal fusion guideline that doesn't actually need any changes except for we're going to do the date of last review on guidelines. Trigger finger and trigger thumb would be, yeah. So there's a whole bunch of other, they had a lot of guidelines, and then most of them are just basically saying, we're going to make things medically necessary instead of included guidelines. So the kind of the meat of this is in the conditions. So they wanted a lot of the neuropathies and mononeuropathies to get PT and OT, as well as a lot of the nerve conditions. Yeah, there's a whole bunch of nerve conditions that they put in the PT OT group. Hydroxyapatite deposition disease, which is also known as pseudo-gout. They wanted joint injections and PTOT. Mallet finger, PTOT. Chondromalacia patellae, they wanted joint injections and PTOT. It's been kind of a controversial diagnosis that we've done in the past. So if you want to talk about that one at all.
Any different on that for injections?
I didn't do the specific evidence review.
I think like half the time people when you have a specific diagnosis when they do joint injections.
So again, we're bringing the whole gamut here. If you want us to dig into something, we can bring it back. If we're expecting that this happens.
Just want to take a minute and look through and see if there's anything that you want to pull out for further discussion.
Remember. Oh. Page numbers. Looking to find what the actual diagnosis is. Oh yeah, there's one, the code description is just various sprains and strains. It's SO3.8 XXA.
No, that's me. So when you get into orthopedics, there are, I think there are 10,000 orthopedic
Oh
codes.
no, there are.
It depends on right or left and
Right.
this or that. So that is a dump of, it's all kinds of sprains and strains and all kinds of joints and things. And that was me. That's not actually what the code description is.
Oh, it's the right and left and all that stuff. Oh, okay.
Yeah.
So
Yeah.
it's just the,
It's just-
gotcha.
I could not
Because I was
type
like,
out all.
okay, gotcha.
Yeah. We do have a spreadsheet you're welcome to look at.
No, that's fine, but I was gonna say, there are more specific diagnoses for
Right,
areas
but that's
where we
just like the
shouldn't-
first
yeah.
one, and then
Gotcha,
all
gotcha,
those
gotcha.
other things are gonna be left,
Then I
right,
saw-
both, neither,
Yeah.
either,
Well, they're unspecified.
Every single part of the body.
unspecified
Every
for
degree.
every joint, every piece.
Okay, yeah, as long as they're not related, because there are some ones that don't have locality or laterality, or sometimes they have a diagnosis.
So some of the, there literally is unspecified sprain of unspecified joints.
Right.
I'm putting those in
I know.
evaluation and medical management.
Okay, good. Because yes, I know.
Specified
That's why I'm
strain.
saying like.
My other one is
Yes.
other injury of unspecified body region.
But it's another specified injury.
As opposed to a
Unspecified.
more specified.
Yeah, there probably is an unspecified injury of unspecified body region.
Right, that's
Unspecified laterality.
I know those.
Of unspecified time frame.
Caused by an unspecified vehicle or.
Unspecified individual. Yeah, okay.
Injury of
Last
unspecified
great
type.
meeting.
Yeah,
And then you have
Or
the
the
very,
ones that are
very
kind of
specific. Run over by bicycle.
Initial encounter, or wait, were you a pedestrian on the sidewalk or in the walkway? That's two different codes.
Or were you vaping?
Or juggling while you were hit.
All right, but we digress.
Yes, they're either overly specific or lack specificity.
Okay, so Max, which codes do you want more input on, or Talia,
No,
or any other member of this group?
nothing jumped out at me.
If I understand correctly, if we got too many codes on the PTOT line and PTOT is prior authorized, you can look at it anyway and say this doesn't make sense, right?
There's always medical tests.
Yeah.
And I think that probably a lot of those neuropathy codes are used before actual definitive diagnosis.
I see.
Or they're used based on clinical symptoms rather than diagnostic. So
I was
sometimes
told by both
So
the
it's
sports
appropriate.
medicine doctors and the orthopedists that they see those codes all the time.
That's
They
what I'm
get a
saying.
referral to
In
them
people that are
from
That's what I'm saying.
unspecified sprain, and then they have to figure out what they're supposed to do. Luckily,
Like,
hopefully the
which
patient
body
can give
part,
them a
yeah.
good history. Exactly.
Yep.
So,
Also, when I'm breaking those things up, yes. Yeah, there's always still.
and even if we don't put it in the PTOG group, they could still see a sports doctor or the orthopedist for a more specific diagnosis, and it might be appropriate for whatever. Yeah. So you guys are good with this?
I have one typo.
Oh,
I
of
found.
course.
Yeah, on her staff recommendations, 2B should be joint.
I have too many guidelines, my finger's tired, I can't get there.
This is page 309.
Oh, yeah, yeah, we don't have, there's no such thing as a joint injection procedure. But spell check didn't catch that one, thank you.
Ariel, you were concerned that this would be too broad.
Yeah. Although our experts felt that it was very appropriate, and the feedback that I got, mostly from the sports docs, because this is really more what they do rather than surgery, is that they actually have a lot of trouble getting patients who really need PT into PT. There's not enough access,
Right,
and
there's an
also their
access. Yeah,
patients don't have cars, or they taken off work, or they go to 3 PT sessions and then they're out of sick time, or they're like, we have the opposite problem of getting people to do appropriate PT.
Yeah.
And then they're like, we unfortunately see people who have like had a knee replacement and couldn't get to PT, and now they're having complications and we have to deal with that. And
PT is not.
This is Chris. Do you know if I've been seeing some like virtual PT options? And
Yes,
would
there-
would that be covered? Because that would address some of those access issues.
there is virtual PT. I believe we treat it in the same fashion as we do in person. I don't believe we have any, I don't know, I'd have to look at our.
But it has parity. That's great.
I'd have to look at, we have like a guideline on,
If it's clinically equivalent, quote unquote.
Yeah.
then it's covered.
yeah,
Right, we get tele.
yeah.
And for the broadband coverage thing, it's relatively inexpensive, so we kind of balance reviewing them versus the amount of visits, so different people do it differently, but often some initial visits are covered no matter what. So I don't think that would be a huge impact based on the finding diagnosis fees. But it's something that we watch because it is hard to balance all that.
Great.
Okay.
This is Chris. I don't mean to poke the bear, but for the hypermobility syndrome, is there any reason that it's different than evaluation and medical management and it's instead evaluation and medical treatment only?
That's just evolving terminology and probably didn't edit. That code grouping, the idea is the same, but the name has been in flux. So
yeah,
it's the same.
what we're gonna have to do is.
Okay.
We're gonna collate all this and bring it back in detail with all the names aligned.
Yeah. But the intent of that group, whatever its name is it will have office visits. And that
Yeah,
includes a
that's
whole
what I
bunch
thought
of
too.
things.
Okay.
We've been working with our other parts at FHA to come up with what's gonna be in there. There's like extended visits and FQHCs code differently than offices, and then there's like home visits, and there's a whole slew of things. Plus, we wanna cover ED visits because people don't know why they go to the ED. They think they've got a serious problem and they have a cold or, whatever. So, yeah, the name and the content of that code group is not set in stone yet, but that idea is what we're trying to get across.
Okay, so it would be bulked in that evaluation and medical management.
Yes, that's
Okay,
probably
it was
the
just a
name we're gonna
typo.
end up with, but
Yeah, I think that's the name, Lambda.
yeah. And if it says
That's the
something
working
different-
title.
Yeah, if it has a different title, it was probably at a different stage in the evolution of this project, and I didn't catch that and edit it, so I apologize.
Well, thanks.
Well, if people are comfortable with this, do you wanna go ahead and vote and on the sports orthopedic topic?
Entertain a motion?
Motion to approve.
I'll second, it's Mary.
Mary the second, all right, we'll vote on the section of sports medicine and orthopedics as just discussed.
Okay, this is Jessica. Antoinette Awachi.
Aye.
Brian Duty.
Aye.
Mary Engrav.
Aye.
Max Kaiser.
Aye.
Lucy Langer.
Aye.
Sarah Love.
Aye.
Chris Pinzon.
Sorry, I had a pop-up come up when I tried to hit my audio.
All right, David Sagner.
Yes.
And Holly Joe Hodges.
Yes.
Motion passes.
Wonderful. We have one last BUP topic, and that's podiatry. I want to beg your indulgence. After this went out for public comment, we got quite an extensive feedback from the Podiatry Association, and they want we haven't been able to set up a meeting with them yet. We have a meeting scheduled, but it's in April, and they want to come to the main meeting and talk. So I thought what would be a useful use of our time would be to go through this, come up with any questions that you have or any concerns, and then when we meet with the podiatrist, we can go through them, and then we can have further discussion with them here in May.
This is on page 328, 328.
So again, this is really for your information and for any questions, concerns, things you want more detail on. We currently don't cover a lot of things for podiatry. Of note, podiatry is an optional Medicaid service, so we don't have to cover it at all. We currently only really cover podiatry for people who have high-risk foot conditions, which we define as diabetes, peripheral neuropathy or nerve problems, I believe maybe vascular disorders, but we'll go through that guideline in a minute. So if you have a high-risk foot problem, you can get various types of nail care, corns and callus treatments, et cetera. Because that's been shown to help prevent ulcers and amputations and other complications. We don't cover routine foot care for people without high-risk conditions. We don't cover bunions, which is when the big toe joint is kind of enlarged and off to the side.
We don't cover hammer toes, which is when a toe is kind of bent under. These can cause pain, walking problems, etc. So the proposal is to not really add a lot of coverage. The podiatrists have some concerns, particularly with our lack of coverage for things like orthotics and some other foot conditions. But to add some very limited coverage with a very tight guideline for bunions and hammer toes for high-risk people that have ulcers or something in those areas. Ingrown toenails are currently, they have covered and uncovered toenail removal treatments with no clear guidelines. Basically, ingrown toenails are already covered, we believe, and that coverage should continue. And then no real changes to our current coverage of high-risk foot care or lack of coverage for not high-risk foot care. And most podiatry conditions will only be available for office visits. Hammer toes and bunions that are not connected to our sort of very explicit guideline will continue to not be covered. So again, this is defined by CMS as an optional benefit. So we have a lot of flexibility in how to manage this. We still need to consider them for our under 21 population through EPSDT. They can also be, you can have various podiatry services approved through an exceptions process if there's a compelling argument for coverage. Serious foot and ankle disorders like fractures or like congenital foot deformities, we already actually cover. They're not part of this review. So if you have a toe fracture that's not the big toe, or you've got some of these other conditions, we currently don't cover them, but like big toe fractures, major foot fractures, ankle fractures, lots of stuff is covered. So if you're wondering like, why aren't we talking about that, those are covered. And they would be covered whether the service was provided by an orthopedic surgeon or a podiatrist, because they both will work on the feet depending on their comfort level and what's going on. Prescription drugs like anti-inflammatory medications are currently covered, unless they have a PA process for all of these. Orthotics and therapeutic shoes. So for example, a lot of diabetic patients with foot problems will have a therapeutic prescription shoe. That actually is part of the Oregon administrative rule. So we are not going to go there either. And it's really a limited coverage for that as well. So sorry, those are all the guardrails around what we have available to discuss. So in conclusion, most of the serious foot and ankle disorders are currently covered. So those are mostly, like I said, either congenital foot deformities or fractures, things like that. We are proposing creating a new code group for preventive foot care in high-risk patients. This would take all of our codes, our diagnosis procedure codes from our current line 164. We would add bunionectomy and hammer toe correction to that grouping. And add the high-risk foot care guideline with a new guideline about this very limited coverage for bunions and hammer toes. Most of the diagnosis and procedure codes that are, so we cover, there's a non-covered line for closed fracture of the phalanges of the foot, so the sort of bones in the middle of the foot, and we would just kind of merge those all into closed fracture of the extremities, except for toe, and just call it closed fracture of the extremity. Most of these are low-cost office treatments. They're walking boots generally, and if there was an extensive fracture, they probably are getting surgery for it, or I don't know. Anyway, so high-risk foot care would become medically necessary and not on a line, same wording, exactly as we currently have covered. Plantar fascia corticosteroid injections, we have a guideline about that. We're going to make that not medically necessary, so we don't need a guideline anymore, we can delete that. There'll be a new guideline for bunionectomy and hammer toe surgery, saying that it would be covered for patients 21 and over, and that actually is evidence-based. These conditions in younger folks, their feet are still growing and developing, and so surgery is really probably not a great idea in younger, not skeleton mature people. You have to have diabetes, peripheral neuropathy, or other conditions that place you at high risk for complications, a history of ulcer or infection related directly to the hammer toe or the bunion. You have had 6 months of conservative therapy, orthotics, modified footwear, wound care, etc. And there has to be significant functional limitations. You can't ambulate, you can't do your MRADLs, can't be employed, etc. And you have adequate vascular perfusion in the lower extremities to tolerate the surgery. This guideline went by the medical director. There's a group of folks that have volunteered to kind of look at guidelines for me. They thought that that was appropriate. And then so most of these conditions, as I mentioned, are going to go into the evaluation of medical management. A couple like pathologic fracture of the toe will go into those fracture of the extremities. And same with, it's mostly lesser toes, fracture of phalanx. And then the main chains will be the hammer toe and the bunion. And then a lot of these procedures that we had a non-covered line, which will be not medically necessary.
We're not covering orthotics, we have to be part of the guideline.
We do
Are you covering for hammer?
in the rule for orthotics, just
For diabetes
Yeah, and as a part of the police.
and part of a brace with the people, but that's ruled.
But we can add, it just seems odd to require failure of orthotics in the guideline note if we don't cover that. For orthotics.
it says, for example, orthotics, modified foot care.
So if you have diabetes, you would get the orthotic.
Yeah, that's not. I mean, or couple, like, that seems. I would estimate probably for people going 30 say we have to fail orthotics, but they're not.
I think we need to update the orthotics rule. Which we could talk to our DME analyst.
I would just have
To
a
align
line.
Coverage.
Yeah, we're gonna add coverage, surgical coverage, it kind of makes sense.
I can follow up with Lacey. She was asking about this anyway.
I'm sorry, what are you proposing?
I will coordinate with our DME analyst at the agency, because she was having questions about the orthotic rule aligning with Kirk's intent for coverage for orthotics.
Okay, so we may have to bring that issue back here as well.
It's tabled
It's
until
all,
May
it's all tabled.
Yeah, okay.
So I will hear what the podiatrists have to say about orthotics. I'm sure they have a lot to say about that.
Yeah, I'm not sure.
Um,
We should have everything.
Yes, we will make sure that if we say you should try an orthotic, we will have them say that you can have an orthotic if you're following.
Yeah.
Are there anything that you guys see, any coverage, anything that you have questions about, anything that you want specifically staff to address? You need a podiatrist.
This is Chris. For the bunionectomy and hammer toe, is my understanding like the only people that are getting this addressed is people who have diabetes, adults with diabetes, because that's all the other end. So if you just have this condition and it's causing significant functional limitations, you would not qualify for coverage.
That's correct, unless you have diabetes, peripheral neuropathy, or another high-risk condition.
Okay, I just keep thinking about the ADLs and like your ability to walk and move with some of these conditions, but that's limited.
Yeah, so the medical director had some discussion about whether or not we should cover it for somebody who doesn't have ADL, who can't do their ADL because they're bunion. It's pretty rare for just a bunion bunions typically are sort of annoying, and they, I think what the decision ended up being is that if it was a severe enough bunion causing MRADL problem, it would probably be an exception.
Or if you had wounds without diabetes that were recurrent wounds, something like that, yeah, then that would typically be approved by exception, but.
And I will entertain what the podiatrists feel like should be covered for bunionectomy.
Yeah, I've just seen a lot of folks who can't get into shoes at all. And so then they end up in the wrong kind of shoes that leads to wounds, and it gets worse. But there's a big scope here that I know we're not covering, so I'm just trying to find a balance.
Yeah, and some of this is also the balance of like, we don't actually have to pay for this service at all, so we're kind of going beyond what we offer more coverage for podiatry than a lot of states and a lot of, so how do we balance
Yeah.
reasonable additional coverage, but we also want people to get the care they need?
Right. And when I think about ADLs, I also see that there's, things including family care, employment activities, and we want them to be functional and be able to work. So it had good examples.
This is Mary. It would be, I think it's a great discussion, and it's one we have all the time of like striking that balance, like you said, because obviously if it's limiting their ADLs and they have other comorbids, that it's putting them at risk of wounds, infection, et cetera. And with the flip side, that you see a ton of requests, like telehealth requests for orthotics for kids and sport, right? Things like that, that don't
Yeah.
appear men. And so what is the, and then obviously there's huge potential for abuse with this one, as there is with any DME product, right? And so just from that perspective too, but agree with your concerns.
Yeah, and I feel like with the EDTS mandate is going to address a lot of the children stuff. This one specifically is for those over 21, so
Yeah,
it would need, I mean,
bunion
we've
repair,
had other situations where I'm sorry, go ahead.
bunion repair in children is actually not recommended, that you need to be skeletally mature, so that if that came through
Mm.
EBS, it'd probably be denied.
Okay.
Unless there's some weird congenital foot thing, I guess. You never, I mean,
Yeah.
it would be bigger probably.
It's under 21, so sometimes like.
Yeah. I feel like we have addressed this for other things, but it does require like way more documentation and evidence than just a simple statement, because of that risk for overuse. But I see people where they are at that point and there's no opening for them outside of the exception if they don't have diabetes and are not in a long-term care facility.
Diabetes, peripheral neuropathy, or other, right? Not just.
Yeah. So I just would put that, maybe when you have the conversation, we could get some guidance on what that might look like if it was very restricted to, a super high risk population that falls into that category. The podiatrists are the ones who are going to see them.
So you want me to, what I'm hearing is, should we broaden bunions just a little bit beyond that high risk population, and if so, who should we broaden it to? Is that the?
Yeah, like, is there a subset of folks who are high risk related to things that don't fall into these conditions that could be that they see, right? They're in the clinical practice. So is there like criteria that they could define, or knowing that we really do need to be as specific as we can to limit the overuse of but trying to get to those people who do have that significant limitation where it is impinging their employment and their ADLs, to the point where they're impaired.
You got this.
Like to what extent? What would that look like?
You didn't write this from scratch. You grabbed it or something.
it's number 5, basically. I'm just wondering, is
Yeah, no,
there
I've
a
read-
way, are there,
Where did I get this? Cause I did,
This was from the medical director's test group, and I think there were a variety of proposals.
Yeah.
And this, some of them were less restrictive than this. So we can take a look at some of those and
Yeah.
discuss with the dietitians.
I think it's based on Medicare.
I think you're probably right.
What was it?
A Medicare.
Okay. Yeah, I remember it coming from somewhere, from some specifics, I don't know what we discussed.